Good morning, everyone. We're going to go ahead and get started here. So hello and welcome to the Ohio Department of Mental Health and Addiction Services Crisis Academy on Older Adults Navigating Crisis Systems. My name is Molly Drelishak. I'm the program coordinator at the Ohio Association of County Behavioral Health Authorities. We are so glad you could join us all this morning. We have a few housekeeping items real quick. We are using Zoom webinar today, so you will not be able to use your microphone or video, which means we cannot hear you nor see you. The chat function is disabled today as well. However, we will be able to send you information through the chat. If you have a question during the presentations, please feel free to add those questions to the Q&A box. We have reserved time for Q&A at the end of each panel presentation. Please keep your questions related to the content and topics we are learning about. If you are having any technical difficulties throughout the training, please contact me. I will be posting my email in the chat box for your convenience. This training has been approved for 3.5 hours of CEs for the following disciplines: social workers, counselors, and prevention and chemical dependency professionals. This training is also approved for 3.25 hours of CLEs for Ohio attorneys and judges. By logging in today, your attendance is tracked. We will not be awarding partial credit. We encourage you to stay on the entire time in order to receive credit. For those in attendance specifically requesting CLEs, there will be a verification code at some random point in the presentation and an activity code shown at the end of the webinar to verify attendance. Please record just the verification code and email it to me in order to receive CLEs. Please note, we are unable to verify attendance for those who joined the webinar by phone. At the end of the webinar, you will receive a link to a two-part evaluation. Please complete both evaluations within 1 week of the webinar in order to receive your CEU certificate. Certificates will be emailed to you approximately 2 weeks after the webinar. Again, for those in attendance specifically requesting CLEs, there will be a verification code shown at a random point in the presentation and an activity code shown at the end of the webinar to verify attendance. Please just record the verification code and email it to me in order to receive CLEs. This webinar is being recorded and will be posted on the Ohio Department of Mental Health and Addiction Services website. I will now hand it over to Director Lori Chris, Director of Mental Health and Addiction Services, and the retired Supreme Court Justice Evelyn Stratton, who will both be providing the opening remarks.
Good morning. Thank you so much, Molly. And I want to thank all of you for being here. We have tremendous registration for this Crisis Academy today. And I think it really emphasizes the importance of understanding that mental health affects people of all ages, and that we know that Ohioans who are older are certainly no exception to that. The challenges that they experience in their day-to-day life with their health and mental health are different than what people of other ages do. And so the considerations in creating opportunities for them to thrive, to be well, to live at home, and to really have that sense of wellness is something that we need to pay distinct attention to and really create distinct opportunities for. I'm really grateful for the partnerships that we have, and you'll see those here today. I want to recognize the Aging and Criminal Justice Mental Illness Task Force of the Ohio Attorney General. That's co-chaired by Judith Brockman, Sylvia Playrath, and Adrena Tart. Adrena's from our department. This is part of the Stepping Up initiative, and it's overseen by Justice Evelyn Stratton. And I'm so grateful, Eve, for your partnership in all things behavioral health, criminal justice. I also want to thank Director Ursel McElroy and the team at the Department of Aging for their partnership. Director McElroy is such a champion for older adults in Ohio living their best lives and living at home, and also a champion for mental health and wellness as well. And so the combination there really just makes her such a terrific partner in this work and on all issues affecting older Ohioans. This task force committee was created to address mental health and addiction in older people in Ohio, making sure that they are living at home, that they're diverted from jail, that they get the crisis care that they need, both for their mental health, their substance use disorder, and their physical health conditions. The committee includes representation from aging and behavioral health networks. So I'd also like to thank the Crisis Academy Planning Committee for your dedication, passion, and involvement in the Ohio Crisis Continuum Task Force work and in the planning for today's event on older adults navigating crisis. Most of all, again, I'd like to thank all of you for dedicating your time today to learn more about this important group of Ohioans and all that can be done to help make sure that they are healthy and well in every way. With that, I'll turn it over to my friend Eve. Justice Stratton, thanks again for all that you do, and we're looking forward to hearing from you.
Thank you so much. And I am so honored to be able to welcome this group. It's amazing how many, we have over 520 registered, which is astounding. I thought we had 50, and then I was blown away at the interest in this issue. This idea was generated a long time ago in the Aging Committee of the Attorney General Task Force that Attorney General Yost and I co-chair, but actually started under Attorney General Mike DeWine. And we were looking at resources for crisis issues for elderly. Nobody really knew what was out there. We were trying to do an environmental scan. Our three co-chairs that Director Chris mentioned were doing a great job looking at all these issues. Then along came Director Chris with her big crisis task force issue. So we merged with them because we believe very much in collaborating, and pretty much worked under that task force and realized that there just needs to be a separate focus on the aging population. They have a lot of the same issues, but they have a lot of different issues, and their issues are probably even more difficult and stronger because they often then have lost their family support, may not have had family support in the first area, can't navigate, don't know the new technology, don't have access to the new technology, get more and more isolated, just so many issues. And just recently, even I had to help an elderly couple of a friend of mine who's had fallen victim to one of the scammers trying to get access to their internet accounts by clicking on something they shouldn't have. And the Aging Commission jumped right in and helped us with that problem. So we're really excited that we are able to be part of this partnership and work together to put this webinar on, but that's just the beginning. Our Aging Committee is now committed to working with the Aging Commission and the Behavioral Health and Recovery Ohio that I'm also a part of to then go forward with the solutions and answers and making sure those resources are created or existed or are accessed. And so there's a lot of work to do, and all of you that are out there can be part of that effort to find those answers and to make this not just a webinar that you put on a shelf and that's it, you got your credit and that's it. Do something, take some action. And I also would like to encourage you to join the Aging Committee of the task force. Anybody can join. I think maybe we could have the information sent out to how to contact Carolyn Bevan from our chairs to join the Aging Commission or Aging Task Force and be part of the action arm, because they meet every quarter by virtual. We did even before the pandemic, so people didn't have to travel, because we're going to be working on solutions that come out of these discussions and this presentation. So again, I want to thank the incredible partnership we've had with so many that are involved in this webinar. And I'm particularly grateful for the partnership with Director Chris and her leadership on the crisis task force, because that is so important to reducing the recidivism, breaking that cycle, and finding solutions. So again, thank you all for joining. Thank you all for being part of it. But afterwards, do something. Thank you.
And I want to thank you, Director Chris, for your continued support of the Crisis Academies. And thank you, Justice Stratton, for your joining us this morning and for your continued dedication to mental health work in the criminal justice system. Now I will pass it over to Renee Smith, NAMI advocate, who will be sharing your experience with Ohio's crisis systems.
Thank you, Mally. Good morning, everyone. I just wanted to thank you, Mally, and also Fonda for inviting me to speak about my experience as an older adult navigating the crisis system. I'm a proud NAMI mommy, and I've been designated so by Rochelle Martin and Terry Russell. I'm only one of several NAMI mommies, and I have other colleagues and friends who are far more aged than myself, that being Ingrid Sylvan, who's in her 90s, Ann Sarin, who's a member of the Adam H. board of Franklin County. She's in her late 70s, approaching her 80s, and myself in my early 60s. We're very proud NAMI mommies, but suffice it to say that this is a distinction that I'm sure all of us would gladly relinquish. As they say, aging isn't for wimps, but what do they say of aging when you have the challenge of caring for a severely and pervasively mental ill loved one? I don't think they've come up with any quote for that as of yet. Now, I'd like to just tell you a little bit about myself and my loved one. I am the mother and legal guardian of a 34-year-old who suffers from schizophrenia, post-traumatic stress disorder, Asperger's syndrome, and anosognosia. That's the illness side of my loved one. On the wellness side of him, he's very intelligent, very brave. He's never been a user of drugs or alcohol, but was stricken with this severe illness. He's a vegetarian and a naturalist by nature. And by virtue of that, he's always had a dislike for medications. We have been linked to a local mental health agency, but we've been without a case manager for over an entire year now. I do receive respite services, and this has been so much a lifesaver for me. My son has been participating in ongoing counseling through his agency. But I know that we're working in a system now that has constraints of dealing with a lot of manpower shortage, and that's had an impact on all of us. So as an older aging adult, we've had to fill in a lot of the gaps, and in some instances, we feel as though we are, in fact, being the case manager. I mentioned the term anosognosia before. I would just like to revisit that real quickly, because that is one of my son's very pervasive symptoms that prevents him from really getting the care that he needs. Anosognosia is probably the most difficult, the most challenging difficulty of our whole journey in mental illness. Referring to data from the Treatment Advocacy Center and NAMI National, we know that 50% of people with schizophrenia and 40% of those with bipolar disorder, they suffer from anosognosia, which is a symptom of severe mental illness that impairs a person's ability to understand and perceive their illness. Because of that, very often we caregivers are left to fill in the gaps along the way. And it can be very debilitating, very tiring, leaving us pretty worn out most of the time. In the system of care, it seems to me as though those who have insight, they actually get the lion's share of resources and treatment, whereas those with anosognosia often fall through the cracks. It's very shocking to me. I find that in our system, there doesn't seem to be many protocols, if any, no practices, nothing in place that is geared toward helping those who most cannot help themselves, those with anosognosia. I've been dealing with the mental health crisis in Ohio, the mental health crisis system in Ohio for approximately 15 years. My son's first hospitalization was in 2009 at Twin Valley Behavioral Health. Based on what I know, Ohio does have probably one of the best, most organized system of care in the United States. Franklin County, in comparison to some other counties, has a very good system as well. We're so fortunate for the many mental health agencies that we do have, some great advocacy agencies, the Adam H boards, Net Care Crisis, and both private and public hospitals. It's not a perfect system, but we're all working for improvements. And I'm always glad to be a part of that process. As an older adult navigating crisis systems and as a caregiver, I find myself moving and existing and actually surviving in two modes of crisis. One I call a chronic existence and the other an acute existence. Both are very physically and emotionally taxing. And as an aging adult, naturally, I'm starting to encounter my own physical ailments, dealing with decreased energy, not feeling well frequently, increased doctor's appointments, hospital visits even. And so, this can be very physically and emotionally demanding. I also have very little family support, as cited earlier. And so this makes it even more challenging. So what I would like to do, I'd like to talk about my day-to-day life in what I call chronic crisis, and then also talk about some aspects of how difficult it is to deal with acute crisis. In the scenario of dealing with chronic crisis from day to day, we live with adult children who suffer from severe psychosis in a lot of instances, delusional thoughts, mood swings, and all of these oftentimes bring very bizarre behaviors with them. I'd like to cite a scenario that I spoke of to Governor DeWine in 2018 when Terry Russell invited me to speak with him to the governor about how difficult it is living with someone with mental illness, in addition to being an older person. Terry had me take with me a Rubbermaid tote, which I called my escape tote. In that tote, I had a small pillow and a couple of warm blankets, because there were many, many occasions when my son's psychosis got so severe that it became so frightening for me that I would have to leave the house and take refuge in my small Toyota Corolla, many times sleeping in the parking lots of 24-hour restaurants where I felt I would have more security there than at home. This is something that repeats itself. We live in fear daily as older people living with someone with severe and pervasive mental illness. But I like to talk about some of the things that are working very well that help me manage my chronic crisis. And one of those things is the respite program. The respite program is offered to me through Concord Counseling, and it has been the probably #1 lifesaver for me. I started participating in that program in 2018. Without this ongoing support of NAMI Franklin County, NAMI Ohio, their education and support groups, without Mental Health America, without Adam H's Consumer Advocacy Council, I don't know where I would be. So those are some of the things that have been helpful and have worked well for me in dealing with my daily life, which feels like a 24-hour crisis. Some of the things that have not worked so well have been just getting and maintaining case management services, especially as it pertains to a person with a lived experience who has anosognosia or complete lack of insight. They're often not very willing to participate, even if they do have the services. So I know that that poses a challenge in the system. And another major challenge is just being in the same household with someone who's presenting all of these types of symptoms. It can be very challenging. It has been difficult, if not impossible, to get housing for our adult loved ones with lived experience, especially if they already live with us. Certainly them being able to get housing in the system has been difficult and impossible. And then the last thing I'd like to mention is the fact that some of us aging adults are still actually having to work as well, and managing, seeing to the safety and well-being of someone who's at home while you are at work is often very challenging. Now I'd like to talk about what I consider the acute crisis of my existence, and that's when we actually need to get help from others to manage an acute crisis scenario where our loved one has decompensated and we need to have assistance to get them to the hospital. Because my son does have anosognosia, it's safe to say that about 90% of his hospitalizations have been by probate order. And that has required the intervention of net care and others. I say some of the very positive things about our current crisis system is the fact that we have had 24-hour access. Things can go very badly at any time of the day or night. And it's very reassuring to know that there's someone there. Sometimes they're just there to listen, even if they feel that we're not at a point where he can be probated, they're there to listen. And certainly in the cases when it's apparent that help is needed, the system seems very efficient when it comes to the probate pre-screening process. And another aspect of acute crisis care that I have found very effective is NetCare's mobile crisis unit led by Sean Daniels. On 2 or 3 occasions, her staff has actually been able to get my son to go to the hospital voluntarily. And that pretty much never happens, him going in voluntarily. So then let's talk just a little bit, save the worst for last, about the things in the crisis system that I think are not working as well. And the first thing I'd like to cite is the bed board, the proverbial bed board. The bed board dictates which hospital our loved one is sent to after they've been evaluated by NetCare. And I'd have to say, based on my personal experience, unfortunately, the bed board does not seem to take into account the true needs of that individual. They simply send them to where the hospital beds are vacant, unfortunately. That's where I step in as an advocate, and I try to emphasize what his needs are and what would work best for him in light of the fact that he has Asperger's syndrome, and as an autistic, doesn't do well to changes and being sent to multiple different hospitals where he has to get used to a brand new setting, in fact, and where he's unfamiliar with the staff there. So, I'd have to say, I know we had one particular incident where we were presented to NetCare with a crisis. And I asked emphatically that my son not be sent to a particular private hospital. But in this crisis, he was totally catatonic. He was not able to speak, not able to even tell you what his name was. And from hearing testimonials of other families, I did not want him to go to this one particular hospital. Well, despite my best efforts to advocate for him not to be sent there, he was sent to this hospital in a catatonic state. And it ended up a very bad scenario for him. And following that hospitalization, he had 10 hospitalizations within a 10-month period. The Adam H. Board, Dr. Delaney Smith, and several others worked with me to get him transferred out of that hospital. But that was a prime example of how the bed board actually placed him in a scenario that was not the best situation for him. And then the other thing that I would like to emphasize about the crisis system that I know that every other adult, my colleagues and friends who are parents and advocates would agree with, is that we are also very fearful. We are always very fearful of police intervention. We know that this is a necessary part of the probate process and crisis management. But despite our best efforts to train and educate police officers, some who are CIT trained and others who are not, the most dangerous and frightening scenarios for us are when we know the police are going to have to be involved in helping to manage a crisis situation. I have to say that most of our incidents have been non-problematic, but there have been a couple that have been met with major concerns where the police officers, even some who are adequately trained, don't seem to have the empathy or the patience to adequately deal with our loved ones. They approach them in a lot of cases as though it's an incidence of domestic violence, and sometimes they're in fact treated criminally. The officers sometimes are not very supportive, and the whole scenario ends up invoking fear. So I would say that in the crisis situation, in the most dire of situations, our major concern as parents, and especially aging parents, is that we want to know that our loved ones can be taken to the hospital without being harmed by the police. You know, I'm just relating to you what my personal experience has been. While I'm grateful for the support of the police, there's still a lot of work that needs to be done in that area. So I'd just like to thank you for letting me expound on what some of my experiences have been. And if there's any questions, or if there's something that I haven't been clear enough on, I welcome any questions.
I just want to thank you, Renee, for sharing your story. You're so articulate about your experience, and I hope it really brings a message of just hope to someone else, you know, experiencing this. And I just hope that you continue to share your story and be a voice of advocacy out there.
Thank you so much.
Molly, before we go on, Renee, Lori Chris, we met that day at the governor's residence, and I just want you to know that Governor DeWine is so grateful for you sharing that experience with him. I'm grateful that you continue to share it here today. We hold that story in our hearts, and it helps us shape everything we're doing to try to be better here in Ohio. And so thank you. What you've done is really causing change. And so I just want to thank you for that.
You're very welcome. I just always appreciate the opportunity to tell the personal stories, and to also have an opportunity to thank you guys for all of the work that you do to provide the best system of care possible. And, you know, we do understand all the constraints.
Thank you, Renee. We're going to move on now to Dr. Ronan Factora, our keynote speaker. He's a Cleveland Clinic geriatrician who will be speaking on risk factors for suicidality in older persons, the impact of social isolation in creating crisis situations, and methods to reduce factors leading to crisis in older persons. So I'll hand it over to you, Dr. Factora.
Thank you very much. Thanks also for inviting me to give this talk. I'm going to share my slides. And also thanks to Ms. Smith for sharing her story. You know, just highlights the fact that the experience of aging really is heterogeneous, especially when you're a caregiver. And as she had mentioned earlier, aging is not for wimps, but you certainly shouldn't be doing it alone. And so at this point, now to talk about this topic of aging as it relates to anticipating needs of older persons in these kind of situations, and I use some cases to highlight it. Hopefully by the time we're done today, you'll be able to identify risk factors, particularly for suicidality in older persons. And then we'll take a little detour, so to speak, change the kind of focus on looking at social isolation and its impact on creating crisis situations in the lives of older persons. And then hopefully look at different ways that we can actually avert these factors, reduce the factors that can lead to crisis in older persons. So, you know, I'm going to use three cases that I'm familiar with through my practice and also with my colleagues' practice to kind of highlight some of the key points related to this problem. So, you know, for this first case, you know, as we go through it, we just wanted you to think about whether or not you'd actually be able to anticipate that there would be a problem coming up. All right, so case one, this is a 60-year-old female who was admitted to the hospital after an intentional overdose of her Remeron and Elavil. So it was a suicide attempt. She has a history of multiple sclerosis. She's wheelchair bound. She has a history of anxiety, asthma, COPD, eczema, major depressive disorder, hypertension. She has a seizure disorder, and she's also been considered morbidly obese. So she's got a lot of medical problems. The issue that brought her to this point was the fact that she was going to become homeless. She was renting a home from her family member who was selling the house, and she didn't have anywhere else to go. She was worried because she was wheelchair bound and was on O2 as well, so her COPD was quite severe. And she also had 3 previous suicide attempts in her lifetime and a history of substance abuse. So she was a cocaine user. So just looking at this case, you can consider, based on all our varied backgrounds, what are the things that could have predicted that this would happen again in her case? I presented to you some of the medical and the social aspects, but there's a couple other things to kind of keep in mind that I didn't really mention here. She's got, she was already on passport. This was winter time. So, thinking about being homeless during the cold weather also is a big deal, impacting her perception of losing her home. She has 2 children, but she has no contact with them. And the family member that was living with her owned the house and was her niece. And she decided to sell the house without any discussion with her about what the implications would be for her. Aside from her family, there's no other social supports. On top of that, she was on Medicaid, she was on disability, she had very limited financial access. There was already problems with utilities in the house. There was no, the niece couldn't pay for the electricity, which is part of the reason why she was selling the home. As a 60-year-old woman, Adult Protective Services was already involved in her case. She was initially sent to a nursing home after her initial hospitalization. And during that hospitalization, they still couldn't address many of these other risk factors that were contributing to her depression, her social situation, and her risk of suicide again. And during her last hospitalization, there was even discussion between her medical team and her mental health team to see whether or not she could be admitted for depression in the inpatient psychiatric unit, but still couldn't be done because her medical care was too complex. She was already on 4 liters of oxygen. She required 8 for this hospitalization, and it was too much for the inpatient psychiatric unit to handle. So, she was ended up being discharged without really getting inpatient mental health care. She was discharged to a nursing home with a visiting psychiatrist who could see her once a week, but she probably needed more frequent visits as a result of that. And then when she was discharged, she was not connected to outpatient mental health care. She was deemed to have intact medical decision-making capacity. She also had her MS flare was kind of worsening. So, and then on top of that, this took place during COVID. And during COVID, all of the outpatient mental health services that were available to her, they all turned to virtual. As you probably are all aware of, because of the pandemic, really weren't able to meet people face to face. So that personal touch, that one-on-one that she really needed was lost during this period of time. So a lot of things going on in her case that made it very complex. And in hindsight, you could see what were the things that kind of led to this point that brought her to this this crisis. So when you think about depression overall, and there's a lot of risk factors that have been identified over time, and this slide highlights what we're aware of. And this just tells you how well studied this topic is. When you look at, on the left side, biological risk factors for depression, there's a lot of comorbidities associated with this, from vascular general health issues, dementia, vascular dementia, diabetes, Parkinson's disease, and on top of the medical issues that you can accumulate over time, you can be genetically predisposed depending upon certain genetic polymorphisms for depression. Okay, so that's the biological side. But on top of that, you have psychosocial risk factors that can also increase your risk of depression, including specific personality attributes, life stressors, social stressors, and then problems with coping and dealing with these issues that you confront over time. If you can't deal with them well, that's another risk factor for depression. I'll just kind of highlight a couple of things here. That poor functional status as a life stressor is a big deal for persons who are older. Loneliness, impaired social support, and perceived social support as social stressors, also big risk factors for depression. So, and I'm highlighting that because those are factors that we know are risk factors, but how often do we actually address these issues? How often do we actually identify these issues in people that we see that have risk factors for depression? Beyond depression itself, the risk factors for suicidality, very similar. Of course, depression is going to be a risk factor. Prior suicide attempt, also risk factor. But then functional impairment, now also a risk factor for suicidality. So a risk factor for depression and for suicide attempt, stressful life events, again, substance abuse, and then physical illness, particularly when a person is early in the disease course. So early, in the diagnosis of end-stage renal disease, early in the diagnosis of Alzheimer's disease. So these new diagnoses make a person more at risk for suicide attempts. And we may not think about that so much when we think about how we deliver bad news to our patients and what that impact is going to be for those individuals, and keeping track to make sure they're processing this information, okay, that they're not alone, and to help them work through that diagnosis. We don't really think about that this much. So, in one trial, suicide ideation, it was common in patients who have depression and major depression. But for those who didn't have depression at all, 7% risk of suicide attempts. So you don't need to have depression in order for you to be suicidal. And I think that's one thing to keep in mind. And that harkens to the many other risk factors that are associated with depression and suicide risk that have nothing to do with major depression overall. So, you think about function in a person who's older. This is really what we, as geriatricians, are focused on. Our goal is to maintain functional independence, and that means being able to take care of yourself in your household and taking care of your person. So when you're thinking about living in the community, you got to be able to arrange your transportation, pay your bills, take your medications properly, get food to the table, cook, do the housework, cleaning, laundry, use your appliances around the house. So those are the instrumental activities of daily living. And beyond that, you have to be able to take care of yourself. So you have to be able to take a shower, bathe, dress yourself, pick out the right clothes to wear for the weather, to do your personal hygiene, brush your teeth, comb your hair, wash your face, go to the bathroom on your own, ambulate, transfer. So, very, very basic care. These are the things that are the threats to independence for older persons. So if you think about the one thing that many older persons really are focused on, it's driving. What are the things that are related to driving? And this really highlights the importance of assessing function for an older person. So you're just looking at this picture overall, what do you see? You got to see an older person at the wheel. You have to be able to see and navigate what's in front of you. So you can see there's a car in front of him along with someone on a motorcycle. You have to be able to see what the obstacles are in front of you. So vision is important, sensory is important. You have to be able to hear sirens behind you. You have to be able to navigate and use the car itself. So he's got like a good driver, 2 hands on the wheel. So a good example. You have to be able to use your hands, your arms, your shoulders to turn the wheel. You have to be able to look left and right behind you, look at the rear view mirror. So mobility also is important. But on top of that, you have to have intact cognition. You have to be able to process all the information in front of you and make the proper decisions to avoid obstacles, to navigate the course that you're going from one place to another, to deal with and anticipate unpredictable events on the road, changes in weather, red lights, pedestrians, other bad drivers, you have to watch out for. So it's a very complex task that we probably just kind of overlook how much goes into driving well. But when you have problems with driving, it can be due to a number of different issues. It could be due to sensory impairment, and from the standpoint of vision and hearing, it could be due to physical impairments like arthritis or stroke or Parkinson's disease, or it could be due to cognitive impairment related to dementia for sure. But even depression and medications can impact cognition. So these are all the things that we think about for an older person in terms of threats to their function. So going back again to that first case and what the risk factors are for this individual, you can see that prior history of depression, prior suicide attempt, worsening chronic illnesses. There's the multiple sclerosis, substance abuse, a lot of chronic illness, and the impact on function, limited social support, financial limitations, risk for homelessness, and then limited mental health support in the context of that particular period in time. Okay, there were interventions that were limited, that were implemented. They tried inpatient psychiatric admission. There was a skilled nursing facility. It was psychiatric follow-up, but still was not enough. Now, she needed a lot more help than what was available to her. So there were a lot of risk factors, even considering this, that were not addressed. And the resources that were necessary to support her and to keep her from that suicide attempt weren't there, wasn't inadequate. And then on top of that, there were factors that really beyond everyone's control. The pandemic was arising, and it really put a damper on many of the things this person needed. So as much as we can predict things that can happen in the future for a person, there are things that we actually can't control. And that COVID pandemic period really highlighted how loneliness and isolation as risk factors really were significant. And they really blew up all of the issues that were already problematic before the pandemic arose. It just made it more so during the pandemic and highlighted where the real gaps were in care. So, we'll think about isolation and loneliness as one of the really side effects of the pandemic that were problematic for our patients. And this is really the focus of my discussion today. So it's important as we talk about this to think about the definitions, because when you're thinking about loneliness and social isolation, we use this kind of, it may use them interchangeably, but when you're looking at scientific studies, we really have to understand what this means. So social isolation means having a low quantity and quality of contact with others. And this is very objective. It can be measured. This is the objective form. So it can be measured using observations of an individual social network. Loneliness is the feeling of isolation, regardless of objective social network size. So this is the subjective counterpoint for social isolation. And the kind of unifying factor behind this is social vulnerability. And this can help explain how social circumstances relate to health and refers to the degree to which one's social situation leaves one susceptible to further social or health-related insults. So there are a couple of indices that can actually measure this: the social vulnerability index, which includes self-report, variables such as socioeconomic status, relationships, social supports, literacy, and living situation. Now, as a doctor, as a physician, these are things that impact the medical care that I provide for my patients, but they're not necessarily things that I address when I see them on a regular basis. So this really tells you that the picture is a lot bigger than what I see in my clinic. So, loneliness itself as a term is very common. Even though it's common, we often will miss it. And even if we see it, it's often unaddressed. Some of the prevalence estimates for loneliness in the United States, depending on how you define it, up to 25% in the general community for older Americans. So that's 1 in 4. So you go down the street and you can see older persons as you walk in the park, in the grocery store, and you can count off, every 4th of them probably going to be considered, they're going to have that perception of loneliness. And this is the same as the data that's available actually in Europe. So it's common, it's very pervasive. So, and we'll use this as a framework for the next discussion. So this is case number 2. So this is another patient that's seen in clinic, an 80-year-old female who's seen in outpatient geriatric clinic for memory loss. It's a problem that I see very frequently. And she's accompanied by her daughter this time, who lives out of state. So the daughter reports that her memory loss has been worsening over the last 2 years. It's been manifested as word finding difficulty, problems with numbers, so she's not able to pay the bills as well as before. She's been having some problems with purchasing items inappropriately. Her house is now filled with duplicate items. And we're not just talking about toilet paper and paper towels or cans of beans. We're talking about buying stuff from the TV, toasters, microwaves. And she's spending a lot of money online. She has gotten lost while driving home from the airport. And she also flooded her house. She left the water running, and she didn't know how to use her insurance. And as a result of that, she got scammed one time. She had to reside in a hotel for a while they actually had to get the house repaired, didn't know what to do. She was residing in an assisted living facility until recently, and that was after her hospitalization, her hospitalization for heart failure. And she ended up wandering out of that skilled nursing facility through an emergency exit. And as a result, she was transferred to a memory care unit, and that's really when her family wanted to be more involved. They didn't really want her to be in a memory care unit at all. So she has a number of medical problems. She has diabetes, she has atrial fibrillation, she has sleep apnea, for which she's not using her CPAP machine, history of heart failure and mitral valve prolapse. She's a number of medications for these conditions. We did cognitive testing using the Montreal Cognitive Assessment. She scored 14 out of 30, which would be considered moderate severity impairment. And there was concern for a diagnosis of dementia based on her performance in the cognitive testing today, and the fact that she was actually functionally impaired. She didn't have any family that was living in the Cleveland area. Her daughter was really from out of state. She had no other friends, no other contacts, and there was no other support locally. And the workup, we recommended standard things, neuroimaging, lab work. We recommended that she get treated for sleep apnea because that can contribute to her problems with a cognitive impairment. And then we recommended that she be residing in a more supervised setting because she was really having challenges living alone. So, in this case, the findings were consistent with dementia. The daughter denies that this is the case, and she's in denial, so she doesn't have dementia at all. She does not want her in a memory care unit. She instead wants to move her to California to an assisted living facility nearby to her. And she's requesting a note from the doctor that it is okay for her to move to an assisted living facility. So some of the challenges or issues related to this case, and she's got a progressive neurodegenerative disorder. There's clues that she's having problems caring for herself. There were absence of any family community supports to watch over her here while she was living in the Cleveland area. Her medical problems were requiring close monitoring and watching for exacerbation. That's important because those medical problems would potentially lead to worsening of her cognition and decline in functional status. There were concerns about her safety. She had wandered out of the skilled nursing facility, so that may suggest that she really needs a place where she has more supervision. And there's a lack of insight from the family about her current diagnosis, her living situation, and her needs. And this really demonstrates how her social isolation, living here by herself with family away, really impacted her safety. The question you want to ask is, could her needs have been anticipated? Could you have prevented any of these crises from happening? Could you averted any of these crises? And could there have been a way to avoid her moving into the memory care unit? Beyond that, what can be done? She's expected to move to California. What should we be telling the daughter to expect next? How can we prepare the family to take care of her when she moves to California? What plan can be developed to ensure that her needs are going to be met, as well as the daughter's needs? So we're not just talking about the person who we're seeing in clinic, but also the person who's in charge of her care. And how can we connect them to the appropriate community resources in a preemptive fashion to avoid these problems? So those are all questions that we actually had in preparing her case before she moved. So now when we think about loneliness and social isolation, we may be considering this kind of separate from the medical or biological issues that are impacting individual, but there are actually some links and interactions that can lead to the same types of outcomes, and that's going to be the development of frailty. So we'll talk about the biology of this a little bit in the next couple of slides. So loneliness itself, when we think about loneliness as a perceived self-perception, a very subjective kind of feeling, it actually does in itself, that feeling does have an effect on cellular function. There's an increase in vascular resistance that's associated with being lonely, and this has all been studied in many observational trials. So, and this is associated with increases in incidences of depression and cognitive deterioration. Loneliness has been associated with, and that increase in vascular resistance has been associated with progression of Alzheimer's disease, development and worsening of obesity, stroke risk, and hypertension. There are changes in the immune system and inflammatory activity that are associated with that perception of loneliness. And these are mediated through glucocorticoids that are excreted at higher levels in the body, pro-inflammatory factors, and all of that increases leukocyte counts, which are associated with inflammation and lymphocyte activity. And then all this leads to an activity in what's called the hypothalamic pituitary adrenal axis, which is kind of our stress reaction axis in the body. And this leads to an increase in sympathetic and adrenergic activity, which again leads to more vascular resistance. So there's a feedback loop where you get lonely. This leads to an activation of factors that leads to an activation of the stress factors in the body, and that itself leads to an increase in vascular resistance over time. So this is how loneliness can actually lead to the development of many of these comorbidities and medical problems. Social isolation in and of itself also has links has biological and clinical impacts. So social isolation as the objective measure is associated with increased developing cardiovascular disease, higher risk of infectious diseases, a higher risk of cognitive impairment and mortality. And once again, social isolation itself is associated with increased inflammatory activity. And these can be measured using blood tests like C-reactive protein and fibrinogen. And this can also be mediated by neuroendocrine stress mechanisms. So again, that hypopituitary adrenal axis that we mentioned earlier with loneliness also activated when a person is socially isolated. This is also associated with the onset of frailty, which we'll talk about in a little bit. And then these effects depend upon the interruption of a social bond. So really objectively being separated from community, from other persons, that's really where the biological impact and clinical impact actually takes place. That perceived social isolation, again, loneliness associated with that increase in the hypopituitary axis activity, increase in catecholamines, and then that increased sensation of a threat. All that leads to increased symptoms of anxiety, hostility, fragmented sleep, fatigue, increase in vascular resistance. It can lead to genetic alterations that are associated with many of these comorbidities. There's a reduction in impulse control, so behaviors start to change as well. Increase in negativity and depressive symptomatology, and then greater age-related deterioration in cognitive ability and dementia risk. So again, social isolation has a real effect on a person's overall health and the downstream of development of many of these medical problems. So just talk about frailty itself. So it's important to understand what frailty actually means. This was actually developed by Linda Fried, and she defined it based on the presence of a couple of characteristics. One is shrinking, just overall shrinking of body mass, particularly muscle mass. And then with regards to muscle mass, not just shrinking, but weakness, so the second factor. So, and that was measured using grip strength. And that also leads to poor endurance, low energy, slowness in movements, and then lower levels of physical activity that may be present in and of itself, but also a consequence of these changes that are associated with frailty. All you need is 3 of these to be considered clinically frail. So you can actually, aside from looking for these characteristics, you can just look at a person. This is the clinical frailty scale that we often use here in the clinic. And just looking at a person overall with regards to their function, you can determine how frail they are. And this clinical frailty scale has been used to predict outcomes like how a person's going to do with surgery, how a person's going to do after CPR. And we use this as a way to kind of measure the impact of things like mobility-related comorbidities and dementia. So it's a scale from 1 to 9. You can look at, just look at the pictures overall, and you can kind of get a sense of what a person would be like as you categorize them. So 1 would be very fit. Number 9 would be terminally ill. And you can see from very fit, you got well, managing well, vulnerable, mildly frail, and moderately frail. And you can see that's all associated with decreases in mobility and reduction in function. So once you get to decline in the instrumental activities of daily living, as we mentioned earlier, so that's driving, managing the medications, finances, you would already be considered mildly frail. Once you start to have problems with basic activities of daily living, you would be considered moderately frail. So, and then when you get to severely frail, this is really when you're having problems with mobility and dependent on a lot of personal care. So you can see how mobility can affect how mobility can be used to determine whether or not a person is frail, but even in persons with dementia, so cognitive impairment, when you have mild dementia, you would already be considered mildly frail because you have impairment in your instrumental activities of daily living. If you have moderate severity dementia, you would already be considered moderately frail because your basic activities of daily living are already being impacted. And then people who have severe dementia, late-stage dementia, they would really fall into these categories overall. So you don't need to measure weight or grip strength or to measure gait speed to determine whether or not a person is frail. You can look at them and you can determine it just based on their function and their activities, where they would fall, and that would be already predictive of how they would do down the line. There's another quick frail scale that we often will use, 4 factors, so fatigue, resistance, ambulation, and medical illnesses as ways to predict whether or not a person is frail. So if you have 1 or 2 of these, you'd be considered pre-frail. If you have 3 to 5 on the scoring scale, it would also be considered frail. So a lot of different ways to measure frailty over time. They're quick and easy. But again, these are the endpoints that we were talking about earlier that loneliness and social isolation could potentially lead to. So frailty itself, we're talking about medical frailty. Frailty is kind of evolved to be defined multidimensionally. Now we can think about frailty physiologically, but there are also definitions that are being devised that think about psychological frailty and social frailty. So psychological frailty is still kind of being developed at this point, but social frailty involves alterations in 3 distinct social needs. So affectation, behavioral conformation, and then status. So all these things can lead to social frailty overall and have the same kind of impact on a person's health and well-being. When you think about frailty alone, and this is physical frailty, frailty itself interacts with other factors, and it can actually make things worse for an individual. So a person who has frailty and have a lot of psychosocial risk factors that are associated with the psychosocial frailty or social determinants of health, that also leads to a reduced capacity to independently carry out your activities of daily living. So you can see how this also will make a situation worse. Frail people who are already frail already have problems with their activities of daily living potentially, and when you put them in a particular social situation, that actually makes it worse for them overall down the line. Pre-frail and frail older adult characteristics, they usually have a smaller social network and the higher levels of loneliness. So once again, you can see how when you just have that physical frailty, there are other factors that are associated with this population that can potentially lead to their frailty getting worse. And in this case, social isolation and loneliness. This actually produces a feedback loop to cause a person to decline faster over time. When you have the presence of social vulnerability factors, so the social determinants of health, these may also predict that frailty may occur sooner. So if you have social isolation, if you have an inadequate environment, inadequate living conditions, or meager resources, those are all risk factors for loss of independence, poverty, lower level of education, the presence of comorbid illnesses, low levels of physical activity, symptoms of depression, cognitive deterioration. All of these can also lead to they can lead to frailty down the line. So if a person is living in a situation where these factors are present, there is a higher probability that they're going to develop physical frailty down the line and have more problems compensating and being able to live independently. So these are people who probably will require more assistance and more resources and are at risk for worse health outcomes as time passes by. And again, like I mentioned earlier, the context amplifies the effect. So that in the context of poverty and social vulnerability, the presence of frailty is linked to higher incidence of geriatric syndromes. And from my standpoint, geriatric syndromes include less physical activity, greater mobility, and the syndromes we look for, urinary incontinence, recurrent falls, depression, and then cognitive disorders. Loneliness is associated with adverse health outcomes, again, geriatric syndromes, and then a higher risk of mortality. And then the biological link for this, again, we're talking about how frailty and these factors all are associated with increased inflammatory factors. Interleukin-6, C-reactive protein, all of this has been present in higher levels in frail and in solitary individuals. And then poor social environment is shown to be significantly impact immunity, and poor social integration has been shown to alter neuroendocrine activity. So that social isolation, that loneliness, when you have the presence of that, it just adds to the presence of frailty and accelerates the process of decline down the line. And there are biological bases for this to take place. And this is really how these are all interlinked. It's really not enough to think about these different factors, frailty, loneliness, and social isolation as individual components that we have to address. They are really related from a biological standpoint. They're related in how they interact with each other, and they're related in how they actually have an additive or maybe even multiplicative effect on a person's health outcomes. So it's important not to address one of these factors, but to address as many as possible to have a positive impact on a person's health. Okay, so thinking again, going back to this case, in terms of this lady. So what are the recommendations that we had? So the key thing is to arrange for an advocate. She was by herself here in Cleveland. She's going to go to California. Family is going to have to be involved in her care. Or a community individual, maybe a guardian is going to be appropriate. We want to make sure that she is in a safe living environment and to make sure that there's no wandering and that her needs are met. We want to provide support to the family or a more appropriate supervised setting. Again, community resources are important for this. Manage chronic medical problems that can lead to her worsening. Discuss with the family expectations about her cognitive impairment. And they're in denial now, But as they watch this person over time, they are more likely to see the cognitive decline and the functional decline, because they're going to be the ones providing that help to the individual, filling in the gaps. And as a clinician and as a community, we have to make sure that we help that person out and take care of them, and anticipate what their future needs are going to be, anticipate what the needs are going to be for this individual in remaining at home. Is that the right place where they're going to be? Are they going to need more social supports? Will the caregiver need more social supports? What's the medical care that they're going to be providing and accessing down the line? Monitoring the functional status also gives a sense of what their care needs are going to be. Looking at the caregiver to make sure that they're not stressed out, because often that caregiver is the last barrier to that person going to a memory care unit or a nursing home. Once the caregiver really is not able to do their job anymore, that's it for us. So, taking care of the caregiver is going to be very important as well. And then scheduled follow-up. We have to make sure that they are watched over time, that we continue to support them and see how they're doing. And then modify and implement the plan of care to make sure that their needs are met. Okay, so one last case. And in this case, we've got a 66-year-old male. This is a person that I saw for a virtual capacity evaluation. It was an APS case. There were some concerns raised about self-neglect. This person was living alone. They had been estranged from their family, no contact for years, no children, never married, no friends, and does not identify anyone that he would trust as a surrogate decision maker. So really an unbefriended older person out in the community doing things by themselves. They can still take care of his basic activities of daily living and most of his instrumental activities of daily living, but there have been some concerns raised about his ability to manage his finances appropriately. He has checks, but doesn't know how to cash them. Doesn't take his medications properly. He doesn't have a phone in his apartment at all. He doesn't have, and that includes a landline and the cell phone. So access to assistance in emergency, it's missing. He needs glasses, but he doesn't have them. He is not able to get his own food, and he doesn't drive. So he just kind of walks or asks people around him for help. So he has neighbors that have been really helpful for him. And we look in his residence, it's sparsely furnished, and there's bed bugs presence. He gets his medical care in the building where he lives, but he can't recall when his last visit was or what medical problems he actually has. Okay. So, we saw this person, did the evaluation. We did the St. Louis University Mental Status Questionnaire. He scored 16 out of 30, which is considered with moderate impairment. We did some other tests. There was impairment noted in those as well. He does have problems with vision. He couldn't do some of our other advanced cognitive testing. And we did a limited physical examination. No abnormalities. And his vitals were okay. Doesn't smoke, doesn't drink, completed high school. We don't know about his medical problems. We know he's socially isolated. He's got cognitive impairment. He probably has impaired decision-making capacity. And we don't know if there's an undiagnosed mental health issue either. So these are the kind of challenges that we have here. So the issues related to this case, what interventions could you implement to address his care needs? So from the standpoint of medical needs, we have to reconnect him to the medical care. From his nutritional needs, we noticed that he had some obesity. We had some old labs that were available for review. He had a low albumin. The overall nutrition was just quite poor, and he didn't have access to good food. And we were worried about his safety. He was living alone with no access to emergency care, and he had no one that he actually identified as a champion. There was also some financial issues related to his case. Wasn't paying the bills, but he also wasn't ensuring that his monies were being used appropriately. And he wasn't really aware of what resources were available to him, including Medicaid. And then there was the question of who would be his champion. Does he need a guardian? Would a payee work out for him? Because there was really no one to help stand up for him. And then where would he live? Is this the right place? Should we find some other location where his needs are more likely to be met? Now, this guy is relatively young, 66 years old. Okay. Now for my clinic, average age of my clinic is 85. But the isolation that he has risks development of more comorbidities with poor control. And if we put the interventions in early, the question is, if we do that, are we going to be able to change the course of his health and his life down the line? So you can kind of see down the line what may happen to him. Is there anything that we can do to steer the ship in a direction that would be considered a more favorable outcome for this person? So if you think about this, these are the things that we kind of thought about: medical, financial, and social. And I'm going to acknowledge that as a doctor, I'm going to be looking from a medical lens. Now, there are a lot of experts at this conference today, and each one of you has your own discipline. So you can look at this case, you can look at all these cases, and there's going to be things that I'm not mentioning, that I'm not addressing, that you feel would be appropriate for these cases. And that is the reason why it really takes more than one person to help out with these individuals. Now, each one of us has a different lens and something else to offer that can help improve this person's life and to address this person's needs. The medical component was just one issue. And we talked about the social isolation and the loneliness as factors that I don't even address, but there may be some other issues that we can actually address as a team for this individual. So, and the goal would be maintenance of independence. So we would we want to think about what that person wants. What are the goals for the patients? What are the threats to his independence? So we have the chronic illnesses, we have the geriatric syndromes as potential threats to him. Are there any preventative interventions that we can put in place? And we can put in place community interventions, family intervention potentially. Now we can talk about screening and vaccination to help to increase his life expectancy, lifestyle recommendations to help to improve his mobility, improve his nutrition, improve his mentation, improve his mood, and then setting up a way to keep track of his well-being and monitoring. And then from my perspective, I would be watching for geriatric syndromes that are all threats to his independence. So delirium in the hospital, dementia, cognitive impairment, depression, falls, malnutrition, urinary incontinence, polypharmacy, and then the super syndrome really is frailty and disability. From the standpoint of this person's care, you can look at it from a couple of different medical lenses. So the 4Ms is a framework for care that is highlighted in what's called age-friendly health systems. And they address the care of populations of older persons looking at 4 different kind of pillars. One is mentation, so cognition, mobility, and the medications, and the medical problems that you take the medications for. And then what matters most. And for individuals, independence is really what people really strive for. And that what matters most is probably the one pillar of the 4Ms that allows us to open the door to other collaborators, other community services, and making sure that it's not just the medical issues that we're taking care of. So, from that standpoint, the medical system can open the door to address things like social isolation and loneliness and these other factors that are associated with poor outcomes and frailty, and use those resources for the best interest of the individual. When you look at specific problems of an older person, you can use this framework called the Wisconsin STAR method. And we use this as a way to kind of train our fellows at the clinic and in multiple academic centers on how to address the problems that a person has individually. So if you look at the STAR, there's 5 elements: medication factors, medical factors, behavioral factors, personal factors, and social factors. The important thing about this perspective is that we're just not focusing on the medical issues. So the social factors and the behavioral factors and even the personal factors, including things like finances, isolation, family stressors, caregiver stressors, environmental issues, those are just as important as addressing the medication factors and medical factors. But once again, as a physician, we spend a lot more time in the medical arena, but we have to utilize the members of our team that can help to address the other elements of the Wisconsin STAR. So we need to make sure that those elements are not ignored and have a plan that encompasses these elements as well. So let's think about the unaddressed issues in case 3. So financial security, how to utilize his resources, his monies to make sure that his medical cares are needed, that he actually has basic elements for living safely in his apartment. He doesn't have a phone. He has limited furniture. What's the other stuff that's missing that he actually needs? Food insecurity, making sure that he has access to good food, nutritious food, and that it's available to him on a regular basis. Even providing something like Meals on Wheels would be something that we could do. That's simple. Housing security, making sure that he is in a place that is meeting his basic care needs, that there's also safety that's integrated into that decision, and then supports. He has some of those elements in the place where he lives right now, and perhaps just bolstering those may be enough, but considering an alternative living arrangement is something to consider. And then connecting him to the community and arranging for an advocate, those are all important for him as well, because he is really by himself on an island, steering the ship, and he doesn't really necessarily know what direction he's going in. He needs someone to help guide him and tell him what's available out there to help him out, and to ensure that the plan that is developed is implemented and that he is doing okay. He needs that champion in order for things to actually work out with him. And these are broader issues. Again, these issues themselves have a profound impact on his health and medical care. These are not issues that we necessarily address as a physician. And we have to make sure that our patients are connected to people in the community that can address these factors. And this helps to overcome those barriers of loneliness and social isolation that really amplify the poor outcomes that are associated with these factors. So connecting them is important. So that connection is really going to be the first step. And I'm just going to give some examples of some Cleveland Clinic programs that we've implemented that have been useful in achieving this goal. So one of the programs that we implemented here in geriatric medicine during the pandemic was the GINA program. So this is a geriatric emergency needs assessment program that was implemented during the pandemic. So I'll describe that a little bit for you. So these occurred in the pandemic. In-person medical visits in the clinic were suspended as of March 2020, like everyone else. The researchers here in geriatric medicine developed this intervention based on the Camberwell assessment of needs for the elderly and the Elder Abuse Suspicion Index to reach individuals who are at risk and most likely to have poor outcomes during public health emergencies. So this is really an evidence-based approach. And there were 28 questions that were used in the screening and involved questions about patient knowledge and perceptions about COVID-19, physical location, contacts, delayed or deferred medical care, social interaction and isolation, mood screening, physical health and well-being, medications and medical supplies, basic needs, and advanced care planning. So pretty limited, very medical focused, but still a couple of questions there about social interaction and isolation, mood, and general well-being that were integrated into the structure. So this was conducted over a handful of months with our fellows, our medical residents and medical students during the geriatric rotations. And we ended up calling Medicare eligible patients in our health system's accountable care organization program. And we conducted 2,162 outreach attempts and completed 1,405 GINA values. So 65% completion rate at this point. Okay, so these patients were about 76 years old on average. We explored food insecurity, delayed deferred care, mental health, substance abuse disorders, firearm safety, advanced directives, and cognitive impairment. Now, just some statistics of people that we actually were able to connect to: 35% reported feeling anxious and depressed, 40% reported delaying or deferring needed medical care. And then 1/3 of the patients reported needing assistance with one or more activities of daily living, and 17% had medical concerns to address during the phone encounter. So they had delayed care, and now they have this lifeline that was asking about medical issues, and 17% of them had concerns that had been deferred during the time frame. Residents refilled medications in 5% of the encounters, and then some even had referral to hospice-based care based on family and patient goals of care. So we were able to connect to people and still assist those who needed assistance for their medications. And then in terms of end-of-life care, also able to achieve some of these great outcomes just by making these contacts. So the program itself allowed for identification of high rates of delayed medical care quickly with a matching intervention. So and then the medium of the outreach was important. So we actually ended up using phone calls because video and telehealth was of mode that was very difficult for many of our older persons to actually utilize without the use of caregivers. And the outcome of this, we actually had planned to use this to broaden access to care by improving coordination of outreach to more vulnerable homebound patients and by focusing more efforts on bridging the digital divide. So the key thing was identifying individuals who were at risk and connecting them to us. And of course, we focused on the medical care, but that was also the opportunity to access other community services and resources that that person needed. And in the limited interaction that we had with this population, we were able to connect individuals to get their medications, 5%, connect them to hospice, based on goals of care as well, in some elements of the population, and also address delayed medical concerns for those individuals as well. So just the impact of one connection in the community already opened the door to address so many different issues overall. So another program that we have at the clinics is virtual capacity evaluations, and I do this in conjunction with Cuyahoga County Adult Protective Services. So the triggers for a virtual geriatric assessment, APS really is the one that observes the following factors. So moderate to severe confusion with risk factors, and lack of supports. So they were demonstrating at-risk behaviors such as wandering, going to casinos, driving, active exploitation with scams. They also were demonstrating confusion on the initial assessment, and then compounded by medical noncompliance and neglect, and often be able to see that they're not taking their medications properly. And they will also demonstrate combativeness with caregivers. They would also activate this virtual assessment if they attempted to contact the PCP, but they couldn't perform the evaluation. And if that person could not be seen in person because there were no supports or transport, there were no appointments coming up, or the person refused to leave the home. And we also did this virtual geriatric assessment if there was an urgency of need for the evaluation. So something was going on that really needed to be taken care of sooner rather than later. So you can see just based on these criteria that these people are generally isolated. They already had comorbidities that were out of control. They also had problems with transportation and had lack of connection to the community. And these factors have been delayed for a long enough period of time that a medical evaluation had to be done sooner. So here's kind of the referral pathway. And after the initial referral, they make an appointment to be done, to have this appointment done virtually. During the virtual visit, we had been using Google Duo platform. I do this evaluation in conjunction with the nurse who's there to conduct our cognitive testing, to do a medication review, to assist with physical examination, get vitals, and then to get collateral information. And then after the assessment is done, we reconnect the physician and nurse to figure out what the plan is going to be for that individual and what the next steps are going to be, including connection to appropriate medical care at whatever location is appropriate for them. So just looking at the outcomes overall, we'd studied the outcomes for a small cohort of the people that we had done these virtual assessments on early on. I won't go through all of these outcomes, but I'm going to highlight a couple of things. Services were offered to 89% of individuals that the virtual capacity evaluation was conducted on. So that's important because when these individuals are assessed, there's a number of different needs beyond the medical care that were identified for that individual, whether it's going to be safety or nutrition or transportation, assistance with finances, but offering them and opening up that door was an important component. And as a result of that, if they accepted resources, many of them were able to remain at home. And I think that APS gets a bad rap as being the agency that puts people in nursing homes. That's actually not the case. Whatever we can do to keep a person at home, that's really what we try to achieve. And then medical care. Before, about 42% of individuals were connected to medical care before the assessment. Afterwards, 82% were reconnected to their medical care afterwards. So that reconnection and bringing that person out of isolation, addressing that loneliness and connecting them to community services and the medical care is probably one of the most important outcomes for the virtual capacity evaluation overall. So that connection, just like the GINA program, is really going to be the important outcome that's going to help this person most down the line. And there are a number of different interventions to do social isolation and loneliness. Not just our programs here, but these have been studied nationally and also globally. So I'll just give you some examples to kind of think about as ways that you can address this particular problem. Because it is just so pervasive. So social facilitation interventions, that's one type of intervention that's available. The primary purpose was to facilitate social interaction with peers or others who may be lonely. The presumption was that the person who's involved would also want to do the same. And the goal was to provide mutual benefit to all the participants involved. And many of these involved group-based activities, so charity-funded friendship clubs, shared interest topic groups, daycare centers, friendship enrichment programs. All but two of these were able to reduce reduce social isolation or loneliness. So another intervention, psychological therapies. So these are therapeutic approaches delivered by trained therapists or health professionals that include things like humor therapy, mindfulness or stress reduction, reminiscence group therapy, or cognitive and social support interventions. All of these also successful in reducing loneliness and had a positive effect on other outcomes like social support, happiness, and life satisfaction. The common feature for all of these, again, is involved facilitated group-based activities. Many of these involve specific therapeutic approaches as well as group interactions. So there may have been some other things going on, individual factors that were addressed that contributed to the success. So there was that broad-based approach, but then some individualization for the people who actually participated. Health and social care provision, we talked about some of these examples earlier, like the GINA program and the virtual capacity evaluations. All these types of interventions involve health, allied health, and/or social care professionals supporting older persons. In this particular study, they actually involved nursing homes, skilled facilities, rehab units to get people more involved in care, to assess what their needs were. And they were often involved with university and community partnerships as well. And so these are the sorts of programs that may also, with community partners, be successful in reducing social isolation. Now, even animal interventions have been shown to actually be beneficial for individuals. So canine or feline animal interventions focusing mainly on animal-assisted therapy. And they had multiple studies, multiple conclusions. Pet attachment could alleviate loneliness by acting as a coping mechanism, possibly by providing social support and companionship. And I'll be an advocate for this because I got a cat and a dog, and sometimes even just having them around makes you feel better. And it's that interaction that was most responsible for reducing loneliness, of human versus human-human interaction. Now, they actually did a comparison for a living dog versus a robotic dog. And I know that this is something that's been developed also with technology. Of course, higher level of attachment was found with a living animal, but both groups showed a significant reduction in loneliness. There was no significant difference in loneliness between the groups overall. So even if you have an artificial pet, not that you wouldn't want a real cat or a real dog, that can still have an impact on loneliness overall. Befriending interventions, these are another form of social facilitation with the aim of formulating new friendships, usually one-on-one, usually involves volunteers. This is a little bit different from social facilitation interventions because it's not necessarily group therapy. The primary aim is to support the lonely individual rather than to promote mutually beneficial relationships. So the volunteer is there to support the individual, not to develop like a mutual relationship. Even telephone projects were successful in alleviating loneliness through making life worth living, generating a sense of belonging, and knowing that there's a friend out there. Just that connection, the most important thing to develop for these individuals. Leisure skills development interventions. These were varied activities, including gardening programs, computer and internet use, voluntary work, and then connection during holidays and sports. These were effective in maintaining social contacts, spending time constructively and having interaction with others. Productive activities were associated with reduction in loneliness. And that was going to be the reading or engaging in hobbies. Of passive consumptive activities were not. So this kind of highlighted that a person had to be doing something actively in order for loneliness to actually be reduced in these types of interventions. Just sitting and watching TV or listening to the radio as a group, that really didn't do the job of reducing loneliness. It had to be more interactive. So the caveats to these types of interventions, and there's so many different ones. There are so many different agencies that can be involved in these interventions. And the proof is out there that these interventions are effective and they're so varied. So many can be implemented in the community just based on what community services and resources are available. There was a variability in the assessment of success, and it's really based on the types of measures that makes comparisons difficult. So that's one kind of caveat, is that how do you compare one to another in measuring success? It depends on how you measure loneliness, how you measure social isolation, and what are the outcomes that you define success by. And then there's also barriers. Some of them are going to be financial, some of them are going to be related to volunteer work, availability of community resources. They are unique to each intervention. But at the same time, these interventions were implemented. The only way to know that the barrier exists is to give it a try. Again, with the goal of providing these resources to individuals who are lonely or socially isolated, the benefit can be there one way or another. So going back to this case again. So we're trying to think about this person, this man, and what can we do to protect his future? One, preserve his finances. So he would benefit from a conservator or a guardian of finances, and to reduce his vulnerability to exploitation and misuse his finances. So it would help to ensure food security. It would be useful to ensure housing security and help to ensure medical care. It would be able to ensure housing security. That's one other thing, is to reduce his vulnerability and to make sure that his utilities are paid for, maintain the adequacy of the housing, identify alternative arrangements if appropriate, and monitor safety in the home. And then connect him to the community. And this it can be done through scheduled periodic monitoring of his health, financial well-being, and monitoring, to be available as a resource at time of need. So he needs that champion, anticipate his needs, be a liaison to the community, to reach out when problems arise and facilitate communication since he can't do it alone, and then provide an opportunity for greater social interaction with community organizations and entities, and then follow him longitudinally to reduce his social isolation, his loneliness, and make sure the plan is implemented and identify future vulnerabilities. So this is what can be done for him. He has a long way to go, but there's a lot of interventions that can impact his life now and can change his course for his life in the future. So the key points that I hope that I'm able to get to you today, there's a physiological relationship of loneliness and social isolation to health, and it's established, and it continues to strengthen as medical literature advances. We have to be able to recognize and address loneliness and social isolation and all their associated risk factors. And we do this to anticipate the person's future needs and then implement interventions to help to prevent that decline that can take place over time. And the link between the intervention's positive effect on health needs, that has to be further established. There's more studies that are needed, but we already have some knowledge there that this is an issue. And the links between social isolation, loneliness, and biological health, they're there, and we can impact overall health as well by addressing these needs. So just kind of one more last thing, just to reiterate what Justice Stratton mentioned earlier, provide all this information to you and tell you how the different ways are available to impact a person's health overall by addressing social isolation and loneliness. The next step is really for each one of us is to take some sort of action, do something to make a difference. If not just the lives of individuals that we're taking care of day to day, but as a community to impact the lives of groups of individuals who are really at risk. So thank you very much. Appreciate your attention, and have a good rest of the conference.
Thank you, Dr. Factora. We just have one question in the Q&A box. It's someone anonymously asked, what is vascular resistance?
So vascular resistance refers to the amount of resistance that blood has to flow from one part of the body to the other. So if you think about a pipe and how flow in the pipe is easier when the pipe is wider, vascular resistance would be the pipe getting smaller, and that's a result of the blood vessel itself getting tighter because of then that would be vascular resistance or blockage or occlusion in that pipe that reduce flow, and that would be something like atherosclerosis. So that would be like a one way to define vascular resistance.
Okay, looks like we don't have any questions in the Q&A box. I'd like to thank you again, Dr. Factora, for your presentation. We're going to move on to Morgan Fitzgerald, the Assistant Chief of Elders Connections Division at the Ohio Department of Aging, and Jacqueline Carver, Clinical Director of the Mental Health and Behavioral Outreach Services. Both of them will be speaking on the impact of social isolation on overall health and wellness, Ohio State Plan on Aging, and evidence-informed strategies to promote social connectedness, and about local implementation of programs and services and how one agency is addressing emotional well-being of older adults. I'll pass this over to Morgan and Jackie.
Thank you so much, Molly. Hopefully you guys are able to see my screen. So good morning, everyone, and thank you so much for joining us today. Thank you for the opportunity to speak with you all. It's really a privilege to be with such a great group of individuals. As Molly said, my name is Morgan Fitzgerald, and I serve as the Assistant Chief of our Elder Connections Division at the Ohio Department of Aging. And our division focuses primarily on the delivery of non-Medicaid home and community-based services and programs for older adults and their family caregivers. We also lead out on Ohio's State Plan on Aging, which is a federal requirement to ensure that we have a really coordinated, collaborated delivery of services across the state. I'm also pleased to be joined by Jacqueline Carver from Area Agency on Aging 3, located in Lima, Ohio. And Jackie serves as the Clinical Director of Mental and Behavioral Health Outreach Services, and you'll be hearing from her in just a little bit. So on this slide today, you'll find our learning objectives for the next hour or so. Today, Jackie and I will be reviewing sort of the intersection of social isolation and health, much of which Dr. Factora already covered, but also the health state strategies to improve social connectedness through evidence-informed programs, also policies and services, and then also regional community-based programs that are proving successful and ensuring older adults are connected and have access to resources to improve mental health and address emotional well-being. So I'm going to kick us off this morning by first discussing some of the impacts of social isolation or lack of connectedness. And then I'll jump into Ohio's State Plan on Aging that's prioritized social connectedness as a statewide focus to improve health and wellness for all older Ohioans. So let's get started. I'm going to kick us off with just the basics, really starting with defining social isolation and loneliness, and again, examining the impact that it can have on overall health. So as Dr. Factora touched on earlier, loneliness and social isolation in older adults are very serious public health risks affecting a very large number of people in our nation and in Ohio, and putting them at risk for dementia and other serious medical conditions. We do know that civic and social engagement is positively associated with improved levels of overall well-being, including both mental and physical health overall. A report from the National Academies of Science, Engineering, and Medicine suggests that nearly a fourth of older adults age 65 and older are socially isolated. And older adults are at an increased risk for low social isolation and loneliness for many reasons, but a few examples are that they're more likely to face factors such as living alone, having a loss of family or friends, chronic illness, hearing loss, and challenges with mobility. And then social isolation happens when you're really apart from others and you do not have connections. This could be the case for older Ohioans who simply lack internet access or transportation access. Even more at risk are our minority populations and vulnerable individuals. Older adults, immigrants, members of the LGBTQ community, victims of elder abuse. These are all individuals at an increased risk of social isolation and loneliness. As Dr. Factora was saying, social isolation is really more of a lack of social contact with others, very objective, which may lead to feelings of loneliness. And then loneliness is more of the feeling of being alone, despite the amount of social contact that you may actually have with others. And while it can be tricky to measure, there is very strong evidence that suggests social isolation and or loneliness have a profound impact on health. And recent studies suggest that social isolation increases a person's risk of premature death, even rivaling those of smoking, obesity, and physical inactivity. Social isolation is also associated with about a 50% increase risk of dementia. And then poor social relationships characterized by social isolation or loneliness have been associated with about a 30% increase of risk for heart disease and a 32% increased risk of stroke. And it's also associated with higher rates of depression, anxiety, and suicide. And then loneliness among heart failure patients was actually associated with a nearly 4 times increased risk of death, 68% increased risk of hospitalization, and 57% increased risk of emergency department visits. So this is a significantly impactful issue. So here we have a closer look at the state of Ohio overall. And this is really a representation of a county's index of social isolation risk factors. So those with the darker blue shades in the state experience heightened risk of social isolation. And according to the American Community Survey, as compiled in America's Health Rankings Senior Report, older Ohioans are at a greater risk for social isolation than older residents of most other states. In fact, Ohio, unfortunately, is in the bottom half of states, 33rd out of 50 states and DC, for the risk of social isolation among adults ages 65 and older. Additionally, more than a quarter of Ohioans 65 and older were identified as living alone, polled over years 2013 to 2017. ODA conducted a 2017 statewide needs assessment survey that also identified social isolation as a key issue for many older Ohioans. In that survey, 16% of respondents reported feeling dissatisfied or very dissatisfied with their life, and 56% reported that they wish they could interact more with people. While there are many avenues an older adult can take to feel less socially isolated, such as staying active, participating in hobby groups, getting involved in local volunteer initiatives, there are plenty of proven strategies a state, regional, and even local community can lead and leverage to support social inclusion for older adults, and many of which you will find within Ohio's State Plan on Aging. So we're really excited to share with you all Ohio's recently released State Plan on Aging. The launch of the 2023 to 2026 State Plan on Aging was the beginning of October in 2022. And this plan serves as a comprehensive roadmap and really a framework to guide the state's aging network on strategies to advance elder justice and equity and to achieve optimal health and well-being for all older Ohioans. This includes prioritizing social connectedness through improving social inclusion and volunteerism throughout the state. And we know that this is an important roadmap to have because unfortunately for just far too many Ohioans, opportunities for healthy aging are out of reach. And we've already spent a bit of time discussing that. Before we explore the core priority of social connectedness, I do just want to take some time to review a few high-level features of the new state plan. So multi-sector partnerships, including public and private, state and local partners, all of you on this call, are required to achieve the state plan goal and vision. I suspect many of you can find yourselves represented on this wheel of partnerships here, but rooted in public and private collaboration, Ohio's plan really ensures that all partners in the aging network are aligned in our approach and that we're all rowing in the same direction to improve the health and well-being of older Ohioans. With a focus on evidence-informed strategies, the outcomes and objectives in Ohio's State Plan on Aging are achievable, but the plan really does require intentional, synchronous efforts to assure that everyone in Ohio can age with grace and dignity, and again, in the settings of their choosing, with rich, meaningful opportunities to contribute and thrive. So here we have the framework for the State Plan on Aging. If you're at all familiar with Ohio's 2020 to 2022 Strategic Action Plan on Aging, or what we refer to as the SAPA, this framework should look pretty darn similar. It's very similar, in fact. And the vision is that Ohio is the best place to age in the nation. And the goal is that all Ohioans live longer, healthier lives with dignity and autonomy, and the disparities and inequities are eliminated. The navy blue boxes in the center of this framework are kind of our 6 priority topics of the plan. And then you'll notice the icons in the navy blue boxes, which represent each of the topics or 15 issues prioritized throughout the plan. And then at the bottom of the framework are the principles of the plan, which include elder justice, equity, and alignment with our federal priorities. So an element of the state plan is our partner or community call to action, which is so appropriate for today's audience. So as I mentioned, this is a really comprehensive plan that does require a cross-sector response. It relies on these collaborative efforts and leveraging our community's strengths, leveraging these key partnerships, engaging and empowering communities to really achieve the goal and vision. Everyone can help implement the state plan through one or more of these action steps, including align, advocate, fund, implement, partner, and evaluate. If you're seeking closer guidance and information on how to achieve these specific action steps, we do actually have an accompanying implementation toolkit. And this toolkit serves as a very critical resource in moving this important work forward. It provides guidance, best practices, tools, and resources that partners can use to engage in this work, and specifically around those 6 action steps. These steps can be achieved by each of you in your organizations and regions. And the goals of the state plan are lofty, but if everyone is working in alignment, we should see improvement in outcomes. Perhaps today, one of you will have an opportunity to fund a state plan strategy or even decide to implement one of the evidence-informed programs highlighted in our strategies. The options are endless. The state plan provides partners many ways to act, so just find your place in the plan and take this as my call to action for all of you to find your place in the state plan on aging. So a bit more details about the state plan. We have identified 9 priority populations in the plan, along with 3 additional populations to whom delivery of Older Americans Act services are prioritized. Priority populations are groups of Ohioans with greatest economic or social needs and who are at the most risk for poor outcomes. Populations were identified based on available data and feedback from our expert stakeholders. Many priority populations represented in the plan are systematically disadvantaged groups of older Ohioans that have had inadequate access to resources and even lack vital supports needed to live long, healthy lives with dignity and autonomy. Because of these reasons, we were really mindful to consider approaches through the state plan strategies that target and tailor policies, services, and programs to Ohio's priority populations. So the state plan includes an overarching goal that all Ohioans live longer, healthier lives, as I said, with dignity and autonomy, and disparities and inequities are eliminated. And we have 4 key outcomes and corresponding objectives that are used to monitor progress toward achieving that overall health and well-being outcome for the overarching goal of the state plan. These 4 outcomes shown on this slide are increased life expectancy, reduce premature death, improve health status, and reduce elder abuse and neglect. Below each outcome, we have SMART objectives, which of course are specific, measurable, achievable, realistic, and time-bound statements to describe how we will measure and track progress toward achieving our desired outcomes. And then we have at least 1 SMART objective included for each of the 19 outcomes throughout the plan. And there are additionally short, intermediate, and long-term targets set for each of those objectives. So I'm going to quickly jump back and take another peek at our 6 priority topics shown here. And the 15 issues prioritized, again, are represented with the icons shown, and they're incorporated throughout the plan. So for example, with the community conditions topic, we have 3 priority issues, including financial stability, quality and affordable housing, and transportation access. Within the healthy living topic, we have nutrition and physical activity as the prioritized issues. Within access to care, we have healthcare coverage and affordability, home and community-based supports, and home care workforce capacity and caregiver supports. Within the social connectedness topic, we have social inclusion and volunteerism. Within population health, the issues prioritized are cognitive health, cardiovascular health, and mental health. And then lastly, but certainly not least, within the preserving independence topic, chronic pain management and falls prevention are the issues prioritized. Each of these 15 issues then have a corresponding outcome in the state plan and at least one SMART objective, sometimes more, as well as priority populations identified and strategies that will achieve our desired outcomes. The topics on the left-hand side of this graphic really represent the factors that impact our health and well-being of older Ohioans, and then they're often driving some of the outcomes that we see in the topics on the right-hand side, which then will demonstrate how we'll know if the health and well-being of older Ohioans is improving. So now I'm going to dive into just a couple more specific examples. As our conversation today is focused on social connectedness and the impact of social isolation, I wanted to focus our topic on social connectedness. So the first page of the priority section for social connectedness outlines the outcomes, objectives, and priority populations for these issues. And here we have the section for social connectedness. And as we have here, we hope to achieve social connectedness through improved social inclusion and improved volunteerism. Then under each stated outcome, we have our corresponding SMART objectives, the priority populations, and those specific short, intermediate, and long-term targets. And those are all detailed in attachment F, as well as all of the data sources that support those. So as just an example here, under the outcome for improved social inclusion, the SMART objective that we've identified is increasing the percent of older adults, ages 60 and older, who reported hardly ever feeling left out. And we want to increase that from 77.4% at baseline to 86% in 2029 for our long-term target. The priority populations specific to this outcome in the plan include older Ohioans of color, those who live alone, those who live in rural or Appalachian regions, those with low income, those who are immigrants or refugees, those with disabilities, and older Ohioans who are female. The second page of each priority section includes the strategy categories for each outcome. And these are really kind of larger groupings of different types of programs or services and policies which are evidence-informed and will achieve our desired outcomes and objectives. So just as an example here, under improved social inclusion, we see that the second strategy category listed is community engagement and social supports. And this strategy category includes programs, policies, and services like community gardens, adult day services, intergenerational communities, and even senior centers. Generally in the state plan, there are kind of two types of strategies that we've included. The first is programs or services, so more at the individual level. And then the second type is really policies or systems. The specific strategies within each of these categories are further detailed in the plan and expanded on in attachment E. And it's filled with hyperlinks and additional resources to really support strategy implementation. The last element of each of those priority sections in the state plan is the local alignment information. The trends identified in our area agencies on aging, regional strategic area plans, were incorporated into the priorities of our state plan. And the local alignment here really summarizes any strategy categories that were not selected by the AAAs in their area plans. And this kind of highlights where the state may need to fill in gaps or other opportunities. And it also includes some summary statistics of alignment across the AAAs cumulatively for that related priority in the plan. So continuing with social connectedness as our example, this section reflects that all 12 of Ohio's AAAs selected social connectedness as a focus area in their plans. And within that focus area, all 12 selected social inclusion as a priority. However, 6 out of 12 selected volunteerism as a priority. So this, again, does indicate that there may be a gap or an opportunity in volunteerism that the state can help support filling. So I'm also just going to briefly review some of those strategies that I was talking about in the attachment around supporting social connectedness. So these strategies include a menu of evidence-informed strategies and, again, a list of resources that provide guidance and information on how to really impact these priorities. And strategies were included in the state plan if they met one or more of our predefined criteria. But that was primarily, evidence of effectiveness, the size of impact on our outcomes, including equity and elder justice, co-benefits, other opportunities given current status, and alignment with the state health improvement plan. This is the strategy section shown on the screen for social inclusion, which falls under our topic of social connectedness, and volunteerism is also included here. Here you'll see the strategy section for social isolation with a list of examples included. And one example shown here is, again, community engagement and social supports, and hyperlinks to those programs or services that support that initiative. Perhaps there are even some of you on this call who are facilitating these services or interested in funding a new program on the list, but do not know where to start. And we have good news for you. We actually have a toolkit to help with that. Again, the implementation toolkit. This was originally designed to strengthen our implementation of the SAPA that I mentioned earlier, but fortunately, this toolkit is completely transferable to use with our state plan on aging. So we really like to regard this toolkit as kind of a one-stop shop for partners to act on the state plan and really move the strategies into action. The 6 sections of the toolkit align with those 6 action steps I spoke to earlier. It provides a ton of guidance, tips, and considerations and resources, and it can be used by a wide range of partners across the state and at the local level. Within each section, the toolkit provides examples of partners in action just to really illustrate what this work can look like in different settings. It includes considerations for advancing elder justice and equity, some key resources and tools or interactive worksheets that actually go along with the content of that section. So due to time, I'm just going to highlight one of these toolkit sections, our strategy selection and implementation worksheets. So the strategy selection worksheet in our implementation toolkit is really a fillable rubric that kind of walks you through selection criteria and helps provide guidance for comparing strategies that you may be considering. As Dr. Factora was saying earlier, there are a lot of different strategies available out there, and narrowing down what works best for you can often be challenging. The worksheet included in this toolkit does focus your evaluation on really what the impact of each strategy could be for the health and well-being of older adults, the relevance of that program to the older adults you serve, and even the ability of resources necessary to fully implement the strategy. The second kind of worksheet on the screen here is the strategy implementation worksheet. And this guides you through considerations and action steps for actually implementing those strategies. The worksheet identifies goals and additional resources as well that the action steps needed to implement your strategy and advance healthy aging. So just really quick, I'm going to wrap us up. I want to bring us back to the beginning of this presentation and really tie this specifically into our state plan. The state plan on aging contains real, tangible, evidence-based, evidence-informed practices, policies, and programs that can impact the health outcomes of older Ohioans. In considering social connectedness, this graphic really depicts examples of strategies found in the state plan and can be implemented and range from upstream efforts all the way to downstream efforts. So there is a place for each partner in this work to influence within their own sector and the health outcomes of older adults. So now I'm really pleased to hand it over to Jackie Carver with Area Agency on Aging 3, located again in Lima, Ohio. And Jackie is going to speak about delivering evidence-informed strategies and programs to reduce social isolation and improve overall mental health and wellness. Jackie?
Thank you, Morgan. I appreciate that. Also, thank you, Dr. Factora and Renee Smith for sharing your story. I really appreciate that. So I came on board to SFY23 in Lima in August of 2021 to relaunch the Stages Behavioral Health Program. You can go to the next slide. So we officially relaunched in September 29th of 2021. The program is designed for individuals ages 60 and over and caregivers of any age, and that includes individual therapy, couples therapy, and family therapy as well. So we cover 7 counties: Allen, Auglaize, Hancock, Hardin, Mercer, Putnam, and Van Wert. Next slide. So there's some preparation to do before relaunching a behavioral health program. So the first step was credentialing, and that was quite the process. It's a little lengthy. So we do bill Medicare, Medicaid, and private insurances. Community outreach and education is very important. So my main goal is I wanted to reduce any stigma associated with receiving mental health services. A lot of time what's portrayed in the media isn't exactly accurate as to what services really are. So I did that in a couple of different ways. I had a brief PowerPoint presentation, and I went to senior housing complexes and presented that. It opened up some really good conversation. I also offered depression screenings. Didn't attract the biggest draw. So then I was thinking, what can I do to, really spread the word about mental health services and how it can be helpful. So then I decided to give emotional well-being bingo a try. So instead of numbers on the cards, there are coping skills, and I would call out coping skills and slide in a little bit of information and education about why those coping skills are helpful, give some research to provide evidence why those are helpful. So that was really fun, and we were able to reach a lot of people by doing that. Next slide. So Stages is growing. It officially relaunched September 29th, 2021. Referrals started coming in early October of 2021. So there were 5 referrals and inquiries. So just people calling about information, maybe calling for a loved one, wanting to see what the program was about. So in October, I had an active caseload of 1. By April 2022, I had 38 referrals and an active caseload of 17. And by January of 2023, had 100 referrals and an active caseload of 38. So thus far, I have had contact with 71 individuals, and I've provided mental health services to 62 individuals. So what I think is crucial to Stages behavioral health program here is that I go into the home to provide therapy services. So that way, I can reach individuals who are isolated either due to mobility issues, physical health issues. And that also allows me to assess the living conditions as well, which gives me a really good inside scoop as to what's happening. So next slide. So, excuse me. These are some common concerns that I see when speaking with individuals in therapy sessions. So of course, what we're talking about today is loneliness and isolation. That is a common concern that is presented. It's interesting though, it's not initially presented at the first time that I meet individuals. A lot of times it's after we've been working together for a little while that they will say, you know, I'm feeling really lonely. I don't really feel connected to other people. So, you know, sometimes there's a little bit of shame attached to that loneliness. So I think that's why it doesn't always come up right away. Fear is another common concern that I see. And this presents in a lot of different ways. Fear of mortality, fear of a new physical health diagnosis, and how is that going to affect me in the future? And because of COVID, fear of leaving the home, either because they don't want COVID again, or they don't want to get COVID for the first time. So a loss of feeling of control and disempowerment is another common theme that I see. So research indicates that as the feeling of control lowers, the symptoms of depression intensify. So this is something that I really want to keep in mind when working with individuals. So I really want to allow them to have a sense of control in the sessions and to really guide the therapy. Also, ongoing effects of childhood trauma is common as well. So it really affects how people through the lifespan and into older adulthood continue to engage and interact in relationships. And this is trauma that maybe began at 6 years of age or middle school. So sometimes individuals are still dealing with bullying that they experienced in school, and that's still affecting their self-esteem and how they interact with others. Also, passive suicidal ideation is something that I hear. So of course, when I talk to somebody for the first time, I want to assess for safety. I want to see if they're experiencing suicidal thoughts, if there's been past attempts. And so I hear quite often, I don't want to commit suicide. I'm not going to harm myself, but I do hope every night when I go to bed that I'm not going to wake up in the morning. Or, you know, I pray that my time is coming soon. So I want to continue to monitor this and, you know, see how this shifts. You know, hopefully it shifts where they no longer have that hope of wanting their time to come soon. And I also want to make sure that doesn't shift into active suicidal ideation. Next slide. So as you've heard earlier, we've defined loneliness and isolation. So this comes from a study that I've referenced. It's in the reference slide. So they identified loneliness as the quality and quantity of relationships versus what is desired by the individual. So when we hear loneliness, sometimes we think of the person is alone, when that's not always the case. They can be in a household where there's other individuals, but they don't feel that connection, or they don't have that quality of relationship that they're hoping for. And then maybe they have a friend outside of their home, but they don't feel, again, that it's the quality, might feel like it's a superficial friendship. Also, isolation, they defined as a lack of access and opportunity to social connectedness. And what I thought was really interesting is that loneliness and isolation contributes to low self-esteem, and low self-esteem contributes to loneliness and isolation. So working with somebody individual therapy to increase their self-esteem can help them feel more comfortable in social situations and reach out to friends and family and feel more comfortable with that. Next slide. So these are the 3 approaches that I tend to use quite often. These are person-centered and strength-based approaches. So what I really want when someone comes to work with me, I want this to be a novel experience for them. I had one individual share with me that I'm tired of going to appointments and hearing what's wrong with me. So I really want to emphasize the strengths that they continue to have and how they can utilize these strengths to reach their identified goals. So really, I want to get to know the individual as a whole and not so much focus on the deficits or the diagnoses that they are already aware of. So person-centered therapy, the founder is Carl Rogers. So this is, active listening, unconditional positive regard, non-judgment, reflecting back when you're in conversation. And so one thing that Carl Rogers has said via one of his YouTube videos is that when he would meet with an individual, he had said that we meet as equals. And I think that's really important that we take a collaborative approach. And I never want to present as an expert on anyone else's life. I want to hear from their perspective. So motivational interviewing, William Miller is the founder. So there's a lot of concepts taken from person-centered therapy that are involved in motivational interviewing. And I am just scratching the surface of these. These all three could be a webinar in itself. So with motivational interviewing, it really addresses ambivalence, especially when contemplating change. So older adults are faced with a lot of life changes, either due to socioeconomic status, change in housing, they lose their spouse, they have to make a lot of decisions. And so just allowing them to express the ambivalence that they have when making those kind of decisions and allowing them to have the time and focusing on readiness to make those decisions. So if you think about the last time you made a really significant decision, usually don't make it in one day. We really want to take our time and explore the costs and benefits and have that time to make a decision. So solution-focused therapy. So Steve DeShazer is the founder of solution-focused therapy. So this focuses on an individual's strengths and how the individual can utilize these strengths to reach their identified goal. So with solution-focused therapy, there's a 0 to 10 scale. So I use this a lot when I'm setting up treatment plans with clients. So I put the treatment plan in the client's words. So it's in their language, the goal that they want to reach, and we scale that. So from 0 to 10, with 10 being you've reached your goal, 0 being no progress, where is that at? So I'm not saying, hey, you need to learn these coping skills or you need to do this. It's what the client is identifying. And I think that gives a lot more meaning to the experience for the client when we're really working with what they truly want to achieve. Also use a lot of mindfulness. That's always helpful. Also, the reason I wanted to bring up these 3 different approaches is because not only can these be helpful in a mental health therapy session, these can be applied to several different services that are offered. And Miller had said in a YouTube video that I referenced that it's not so much the interventions, but it's a way of being with somebody. So how are we when we're in conversation with the older adult that we're working with? Next slide. So trauma-informed care, again, this can easily be a webinar all in itself. So I'm just going to barely scratch the surface here. But I think it's something that's really important to keep in mind when we're working with individuals. So when people experience trauma, they also adapt and find ways to survive that situation. And these survival skills become automatic behaviors, and they carry on through the lifespan into older adulthood, especially if the trauma is unresolved. So just as an example, if a child is growing up in an abusive household and they find that running from the household is helpful we have the flight, fight, or freeze, then that's going to become an automatic behavior. And that's something that's going to be utilized throughout the lifespan, sometimes into older adulthood if it's not resolved or processed. And so this may present in several different ways. They may, when a relationship becomes complicated, they may run from their relationship. When a job feels uneasy or there's conflict, they may run from the job. So really keeping this in mind when working with individuals. Also, when there's trauma, the capacity and tolerance to manage stress is lower. So we may get a reaction that we don't anticipate. For example, I had to reschedule an individual, and this is the first time I had to reschedule with her, and she became very upset and felt like I was trying to trick her into thinking that I cared about her and that I really didn't. And then as we talked more, she talked about some trauma that she had experienced during childhood. And so that was most likely a response to that, not so much me personally. Also, the way that a provider approaches and works with an individual makes a difference. So the last thing I want to do is create some kind of power differential. Like I said, I don't want to come across as an expert or like an authority figure. I want to work as equals. So typically when people experience trauma, they feel a loss of power, a loss of control, they feel helplessness. So really keeping that in mind with how we address and work with an individual. So when I meet somebody for the first time and they come in for an assessment, I will ask them, why did you decide to come to this appointment today? So I'm giving that back to them. Why did you make this decision? When I go to home visits, the arrangement of the furniture isn't always conducive to a therapy session, or sometimes there's, a lack of furniture, there's not a place to sit down. So I don't want to stand while I'm doing the session. I want to be at the same level. So I take my stool with me, and that way we can be at the same level working as equals. Next slide. So this is my favorite part. These are success stories. I've changed names and information to protect confidentiality. And this success belongs to the clients. I give them all the credit for the progress that they have made. So Jane is in her 70s. When I started working with Jane, she was actively experiencing auditory hallucinations and paranoia. And because of this, she was isolating from friends, family, especially family. She did not feel safe with them any longer because of the paranoia. Jane had a previous suicide attempt, and she would call me almost every day because she felt scared because of the symptoms she was experiencing. She was also experiencing suicidal ideation. So of course, wanted to continue to assess for safety. We made a treatment plan and a safety plan. And so now Jane is working part-time. She is spending time with friends and family. She's reconnected with her family, which has made a big difference. She advocates for herself. If she feels for any reason her medication is not doing what it's supposed to, she will call her doctor. No longer having thoughts of suicide, still having auditory hallucinations, but to a lesser intensity and frequency than before. And Jane recently told me, I'm not ashamed anymore. And she feels comfortable sharing her story with her family and letting them know what she's been experiencing. Jane also has been sending a lot of referrals to Stages Behavioral Health. So she is now also a big advocate for mental health services. So really happy for Jane. Then Hope, I started working with Hope after she had a traumatic experience with COVID. Hope is in her 60s. She was afraid to leave the house after her experience with COVID. So she was willing to let me come into the home, which was a big step for Hope. And when I would go and see her, she would still be in her night clothes, pretty down, pretty tearful. She had identified that she wanted to get back to church and she wanted to be involved with friends and family again. And so I was able to offer Hope EMDR because of the trauma that she had experienced, which she found to be really helpful. So Hope is now going to church every weekend. She's doing activities that she enjoys. She's back working in her garden, which she really likes to do. She loves to decorate for holidays. I walked in during the holiday season. It was like a winter wonderland. It was really cool to see. And she has more exciting weekend plans than I ever do. So just really happy for Hope as well and the changes that she has made. Still working with Hope at that 0 to 10 scale. She is at a 9, so she's almost completely achieved the goal that she had identified. So now we're just working to get it to a 9.5 and seeing what she can do to gradually make it to that 10 on that scale. So we're excited about the future of Stages Behavioral Health. Have a lot of ideas, working on groups to increase that socialization, and I'm really wanting to incorporate arts and music into those groups. And also, just continuing to expand services, substance use services, I think is really important to address with the older adult population. So just excited what this will continue to bring. Next slide. So there's my contact information. I love to talk about mental health. I love to learn from other people. So feel free to contact me with anything you want to share or any questions. And there's the references.
Thank you, Morgan, Jackie. I think it's so important that we remember that, and we have all felt this young and old about social isolations and some of the strategies we can carry on with into the future. We do have one question from an anonymous attendee. They say, the Work Area Agency on Aging is doing amazing. Is this in every county? I did a quick search, but didn't see it for my Butler County where I work.
So like I said, Stages Behavioral Health covers the 7 counties that I had mentioned. I don't know about the other area agencies on aging, if they are working to implement something similar, but hopefully it continues to expand and grow so we can reach as many people as possible.
Fantastic. And it looks like there's one more question asking about contact information, but I can answer that real quick. We'll be sending all the presentation materials from the Academy today in an email later today with evaluations. I just want to thank you and Morgan and Jackie again for a wonderful presentation. Before we move on, I'm going to actually show, this is the random point for our CLE verification. So for those in attendance requesting CLEs, here is the verification code. Please email it to me. I'll drop my email in the chat box real quick here as well. Just give everybody a moment to write that down real quick. Okay, we'll move on. All right. Now I will pass it over to Adrina Tart, a Special Populations Program Coordinator at the Medical Director's Office, Bureau of Cultural Competency. and co-chair of the AG-CJMI Task Force Aging Committee. She will be facilitating the next panel here. Adrena with her colleague Rebecca Grimm and the Planning Committee have been instrumental in coordinating this Crisis Academy with us. Thank you to you both and all who participated in the committee for your hard work pulling this Crisis Academy together. And now I'll just pass it over to Adrena.
Thank you, Molly. I appreciate it. And welcome, everyone. This is an awesome Older Adult Crisis Academy. If all of our presenters can come on video and we can begin to just do some preliminary introductions, and then we will get into more of the detailed questions. Just a little bit about this next section that we're going to be talking about. Ohio MOS onboarded a crisis continuum task force last year, and it looked at our crisis continuum across the state. And by doing that, we were able to do some planning work. So our AG Criminal Justice Mental Illness Task Force Aging Committee sat on some of those crisis planning meetings, which was so valuable because it really looked at older adults and their needs in particular. So one of the things that we decided to do with this panel is to kind of pull our practitioners together and let them just kind of talk and share about that real work that they do in their line of business. So to just get us started, I wanted to kind of let them introduce themselves, and then we will then kind of go into a little bit more detailed questioning. So do we have Dr. Stroll on? Or Jennifer, are you speaking on Netcare today?
Hi, I am Jen Nims. I am currently the program manager of the community probate team with Netcare Access. I do believe this is only in Franklin County. I don't think the other counties have this, but my team goes out and will try to get people in a mental health crisis into a hospital voluntarily, or we can file a probate with the probate court and have the sheriffs bring them in. I have been in crisis work for almost 18 years and here on the probate team for 2 years. We do get older adults referred to us. Oftentimes they do not need a probate. So I'm interested to hear what other places are offering as far as services.
Thank you, Jennifer. And Dr. Mehta, if you can tell us about yourself and your role and the work you do with older adults.
Hi, everyone. Thanks for having me. My name is Dr. Napur Mehta. I'm an internal medicine physician, primary care doctor. I'm the co-founder and chief medical officer of an innovative new practice in Northeast Ohio called Heyday Health. Heyday Health is a house calls and telemedicine practice that's designed for the needs of older adults in particular. I think coming out of the pandemic, we saw a lot of folks who needed access to care, but for either reasons of frailty or concerns for picking up new infections, were unable to leave the home. And we built Heyday Health as a practice around the needs of older adults who either could not or did not want to leave their home to access primary care. So the practice has been up and running for about 2 years. We're in 8 counties in Northeast Ohio and have been seeing mostly older adults in their homes via, again, as I said, in-person house calls as well as telemedicine. So sort of combining the best of both worlds in terms of relationship building by being in the home and understanding the true lived circumstances of patients and their families, but also being able to provide a 24/7 access model as seniors, obviously don't just have health needs during the 8 to 5 hours of an office practice. So, excited to be sharing a little bit about our experience and from hearing from others, and look forward to the conversation. Thank you.
Thank you. And Dr. White? if you could share with us your role and how you interface with older adults.
Thank you for having me today. So I'm Karen White. I'm a board certified geropsychologist. I work at the VA presently and also teach at Case Western University and on several committees involving older adults. So I've worked in a vast range of continuum of care for older adults at the VA, including rehabilitation, physical medicine rehabilitation, long-term care, outpatient primary care, dementia care coordination, and caregiver support. So a lot of what I do focuses on psychiatric differential diagnosis, cognitive assessment, a thorough functional assessment, and when indicated, and often with our patients, a decision-making capacity evaluation. So that's an area I'm pretty passionate about, is thorough cognitive assessment, and in particular executive functioning. And I'm working on a committee with the Ohio Attorney General's Office on best practices for capacity evaluation too. So presently I'm working 100% virtual, providing evidence-based psychotherapies, largely adults older in age as well, and that's with the VA for our VISN catchment area. So that's Michigan, Indiana, Ohio. So kind of a greater range than I had been working before. Also involved in a long COVID consultation project. So some of the nuances there as we come out of the pandemic and resources for folks. So a lot of different involvements across the board. I was on the APS team committee. And again, I teach aging and development to undergrads at Case, and they're trying to target the younger groups with an intergenerational approach and teaching them how to advocate and write to their legislators about needs of older adults. So trying to stay involved wherever I can and continue evolving with that.
Wonderful. Thank you, Dr. White. And Ms. Varga, if you could share your role, as well as not only your interface with older adults, but kind of explain what an I-team is for us.
Certainly. First of all, I'd like to express my appreciation for the opportunity to participate here today. I'm really glad to be here. My name is Kate Varga. I am currently the supervisor for Fairfield County Adult Protective Services. I've been in this position for 3 years, a little over 3 years. Prior to that, I was an intake supervisor for Child Protective Services. So a lot of time in protective services. A little bit about Adult Protective Services. We assist adults age 60 years of age and older who've been abused, neglected, or exploited, who are unable to protect themselves and may not have any supports. Fairfield County APS workers partner with first responders and older adult serving entities of all areas to assure the safety of the older adults in our community, to determine whether the concerns that have been reported to us are true or not true, and to attempt to discern why those concerns have happened in the first place. In serving these older adults, we link services to them to work on alleviating what has caused those concerns in the first place, and to assist them to be successful living in the least restrictive environment as possible. Fairfield County Protective Services assesses concerns for older adults in 6 screening categories, and that's abuse, neglect by others, self-neglect, emotional maltreatment, sexual abuse, and exploitation. The majority of the services APS provides results from collaboration with the older adult as well as older adult serving agencies and departments. We do have a wonderful older adult I-team here in Fairfield County. We meet monthly for an hour and a half. Members of the older adult I-team are from anywhere from mental health providers. We have a couple of doctors that do participate on the I-team. the coroner's office, some attorneys that provide guardianship services, Meals on Wheels, who provides so many services within our county. Just there's a plethora of folks. Fire departments come, law enforcement, both the sheriff's office and the local police department. We do meet monthly for an hour and a half. We are currently in the second year of doing a lot of cross training between the systems, agencies and departments. This was something that in talking during I-Team, everyone felt like this was a needed service, especially as we are inviting more folks to the table, and we want to have a full understanding of what everybody does and how everyone can contribute to the services to our older adults in the community. When we meet, we also share any updates we have in our respective areas, and we have client presentations. We discuss like cases and sometimes not even like cases. And we do this in order to collaborate with other services already linked to the individual, for all of us to participate in group decision-making regarding next steps for the individual, and to link new services as appropriate and needed for our older adults. This was addressed by Dr. Factora in his presentation, and identifying professionals with needs and solutions from their own practice lens. And we meet on the second Tuesday of each month.
Thank you. That was wonderful, and really do appreciate that. And finally, Dr. Stroll, if you could introduce yourself and tell us about some of the work that you do and some of the issues that we should know about older adults in crisis.
Hi, thanks for having us. I'm here with Jen Nims today, who's our manager over our probate program. We both work for NetCare, which is a 50-year-old now public community mental health center located in the Franklinton neighborhood in Columbus. We are an organization that addresses folks primarily in crisis. So we have done a variety of things over time. We're actually a collection of 10 different programs under one umbrella. All of our programs, one way or another, interface with older adults. But there are two that disproportionately address older adults, and that's what we can lend some light to today. Those two programs are our probate program. One of those is our probate program. Let me talk a little bit about what that means. In Ohio, if there is a concern about someone's mental health, whether it's because they're suicidal, they're homicidal, they're unable to care for themselves, or they would benefit from psychiatric admission, and they're not willing to receive services to address those things voluntarily, that is where we get into the involuntary process or the probate process. Each mental health board in Ohio, there's 50 some of those, addresses this differently. Franklin's is a little bit unique, relatively speaking, in that our board designates the authority and the responsibility for screening folks for the appropriateness of that process to us. So we have a team that operates 5 days a week in court hours, and we respond to one of anybody, especially from the community, hospitals, case managers, things like that, who have an imminent safety concern about somebody that they're taking care of. Our program is unique in that we can gather information from both our clinical care record and external records, and then actually try to go see that person in person long enough to figure out what's going on with you today and are you at risk today. So as you might imagine, as folks age, whether they're pre-existing mental health problems or onset of memory impairment become prominent, and that's something that needs to be addressed. The other thing that we do that's, I think, innovative across counties in Ohio is we have a forensic program, and that usually involves folks who are involved with the courts in the context of their mental illness. A subset of that program, though, is actually notably different than that. And what that is that we partner with the Franklin County Agency on Aging. And when they have a consumer who they believe is at risk, usually memory impairment, could be any mental illness, but usually memory impairment. They can refer those folks to our board certified forensic psychologists for a formal evaluation of their memory and what needs to happen next. So as a safety net agency, we often serve to make sure that people get what they need, but also respect the bounds of the law and autonomy wherever possible. And so those two programs in this context are probably the ones that stick out more than not.
Thank you so much. That was very helpful. And I guess, Jennifer, I would like to start with you and ask you one of the first questions. Over your period of time serving within your organization, have you seen any particular trends that we need to be aware of and may be helpful as we begin to develop our work across the state in crisis as it relates to older adults?
Right. Well, unfortunately, the trend, I don't know if you guys all heard Renee talking at the beginning of this, but her experience with the lack of case management, it's like they're linked with an agency. And used to be the problem was overworked case managers. And now the problem is no case managers. So I think that is unfortunate. And here at NetCare, we've had this experience too, where we have programs and we have, great ideas ready to go, but the staff shortage is a problem. The other thing is we get a lot of referrals in the probate team we get police, family, neighbors, agencies, and they most often do not need a probate. Like a probate is for an immediate crisis. They need to get into an ER, they need to get in a hospital, and that will solve a lot of this. For older adults, this will not solve their problems. It's an ongoing problem that hospitalization won't help. So they need more support. All morning we've been talking about the lack of support for those without like natural friends, family support. In-home services, reminders to take their meds, someone keeping an eye, making sure they're eating. So these aren't necessarily probatable problems. And I think that is the trend, that we just don't always know what's out there. People are eligible for services and they're not signed up because they didn't know, or just the lack of staffing.
Thank you. Dr. Varga, in your work with your I-teams, how do you address situations like Jennifer was alluding to? Because you have multiple systems at the table with understanding what's out there.
So we can pull on each other's resources. However, just like Jen said, there's such a lack in the workforce that so many areas don't have the capacity to assist our older adults. A lot of times it feels like we're just putting Band-Aids on. So in talking about gaps in services, this is not a gap in service other than we don't have the manpower to fill up those services that we have available to our older adults.
Okay, thank you. Dr. Stroll, addressing this gap, what do you think it really is? What is the problem in terms of the crisis, other than the pandemic, that you think we are really struggling with trying to keep workforce?
It's a lot of things. We have a lot of different headwinds coming at workforce. We have positions that are traditionally underpaid. And as college gets more and more expensive, our learners aren't stupid. They say, wow, I'm taking out more and more loans. And at the end of the day, what is my earning potential once I've taken now tens of thousands of dollars of loans? And that's just undergraduate. So that's to address some licensed folks. There's this cliff coming where college is getting more and more unaffordable at the exact same time that pay is not increasing. And now the real question is, how would I pay this back? We also have, and this is not poo-poo at licensure, but we have right now there's a very strong divide between licensed folks and unlicensed folks. And there are good reasons for that. But when you're already short on staff, that very rigid fence can be more problematic than not. I'm not suggesting that we simply remove the fence and just have a free-for-all. That's not at all my intention. But it is exacerbated by an education crisis and just workforce crisis generally. It's oft said, and I'm sorry, I'm just joining now. Folks have a real decision, especially in unlicensed positions right now. Should I go work in the behavioral health workforce, or should I go work at Amazon? Because they both pay the same. So we really need to figure out some of how we value this and how we remunerate it. There is, in my mind, it was really noble that we stood up a community behavioral health system in the auspice of deinstitutionalizing people with the revolution in medication that happened in the 50s and 60s. And the vision for that was really smart. We said, look, folks can go live independently, and we're going to take that same money that we would use to hospitalize folks and have them go live independently. And that makes all the sense in the world, as long as the funding matches the growth curve in healthcare generally. And we are now in a separate but equal system. Separate but equal is not really all that equal most times. And unfortunately, I think that's kind of where we're at, is our system has not kept pace with both just the behavioral health need, but also the rest of healthcare. And that's something that we really need to straighten out.
Thank you. Thank you for that. Dr. White, all of the programs that you identify that the VA offers, how can the community-based organizations kind of work with you and partner with you across the systems?
That's a great question. Yeah, my services will be for veterans, but we know we have a lot of veterans we see in our communities too. So those are the only folks that I can serve. And I know the VA system can be a bit challenging at times, and we all feel like we're working in different silos and dealing with these gaps in systems of care for sure. A lot of times with the VA as well, anything that happens outside the walls of the VA are difficult to kind of interface with. But I will, our patients are living in the community. So there's kind of a gap in care there just by nature of that system. That's from my clinical just experience and perspective, not speaking on behalf of the VA. But I do think that's building and growing. There's been a lot more community-based programming in the community with the Justice Center, Justice Outreach, people that are meeting veterans in the community for that, and programs such as home-based primary care, the caregiver support programming. So I do think it is starting to branch out, needs to be a lot more for that. VA providers now serve on iTeams. I'm hoping across the state, but I know that's something that's been established at least in the last 10 years with my involvement with the APSI team in Cuyahoga County. And when I moved out, someone else took that position. So it's really good to see that involvement outside of our clinical duties, and that it was supported by administration. There's been processes developed as well that I think need to continue to grow. For instance, on our iTeam, there was a developed standard B7 letter that basically was a standardized process that the VA provider could disclose and converse with Adult Protective Service workers so that we could coordinate care. I mean, that's fairly new as well. But more initiatives like that and advocacy is really, I think that's really key, so that we can open those doors and not have that blocked when we're trying to communicate among systems like that. And being a federal system, there are a lot of legalities to that, but we've been able to develop processes to help. Now, that being said, for veterans in your care, it's hard to kind of get access in the VA, but every veteran has a primary care provider assigned, a mental health treatment coordinator assigned, and I always say, when in doubt, call a patient advocate, because they will help there's advocates at every site that their job is to help kind of coordinate care with veterans, at least get them to the right provider, social work service, or somebody that can help in that regard. We do have a lot of services too that people may not know about, such as, well, we do have geriatric specific services, which is growing and becoming a lot more robust, at least at our facility, and the training programs across the nation. In addition, a lot of the board certified geropsychologists are coming from the VA. So we have a lot of specialists being developed there. Finally, one plug too is we have a lot of innovation for access to virtual care. So veterans can receive VA issued iPad tablets. That's very user friendly. We often use a caregiver to help, or a home care worker, but we can get them access to care in their home when otherwise they wouldn't be able to use the technology. So there's some unique things there that I think do help. And that way we can partner with agencies or providers or care providers in their home as well as part of their care. So just a few areas. I hope that helps.
Yes, that was wonderful. Dr. Mehta, since you see a lot of older adults, is there anything uniquely that you would like to share with the audience that would be helpful to know about caring and supporting older adults? Those things that we just may not really be in tune to.
Yeah, well, I'm sure I will not be telling this group of mental health professionals anything you don't already know. But I think as a primary care physician, we really are on the front lines and seeing a wide variety of patients and the ways that they present. I think one of the things that we've really been focused on trying to address is the epidemic of loneliness. Lots of social isolation in the home, lots of people who are having trouble with transportation, lots of folks who may or may not have good family support. And so in our practice, we've built a role that we call the health ally. Think about the health ally sort of like a community health worker or a care navigator. They've carried lots of different names, but in our context, we really hire and train for folks who can be a listening ear, can help to make those connections. I think that Dr. White was mentioning between the various elements of our incredibly complicated healthcare system, not just within the VA. I mean, I think everyone would agree that our healthcare system is incredibly complicated. And these are folks that, yes, we are managing their sort of medical concerns, the standard, hypertension and dyslipidemia, heart failure, COPD. But of course, there is lots of underlying either overt or occult, mental health illness. And one of the things that I think is really critical is ensuring that folks have access. And Dr. White sort of touched on this a little bit with telehealth and making sure that people do feel like they don't have to wait for an appointment, or that they don't have to sort of get a ride and sit in a waiting room with a bunch of other people who might be coughing and spreading germs, but rather that they can reach a multidisciplinary care team that can address their concerns, regardless of what they are, at the click of a button or a pickup of a phone. And it's somebody who knows them and knows their concerns. And that from our point of view, we are picking up on cues and signals before they turn into crisis. Yes, we do need to be able to respond to crisis. We also need to be able to pick up on signals before they turn into crisis and try our best to intervene, either directly by perhaps doing a house call or a home visit, or maybe indirectly by reaching out to family members, caregivers, home health aides. We work very closely with a lot of partners that I'm sure you're all familiar with, like the Area Department of Aging, or in our area, it's called Direction Home. APS has been really helpful in a lot of situations. And so I think wrapping our arms around a patient in totality, I think, is really our collective goal, and should be our collective goal as we think about how we work across disciplines to ultimately provide, the best care possible for the folks that we're seeing. So
That's
I think there's
wonderful.
lots of opportunities, I think, for us to collaborate, to work together, to pay attention, frankly, so that we're getting ahead of things before they
And just a
become
follow-up
dire.
question to that. Since you have a navigator, do you have any built-in infrastructure that you're using right now to pull in the systems for that type of communication?
In terms of, do you
To
mean like in
best
terms of
work
getting
with-
records and sort of making sure that we're communicating well?
Yes, and how to work across systems with all of the various needs that you may see before the crisis occurs.
Sure. Yeah, I think that there's both electronic and sort of, frankly, human connections, right? So on the electronic side, I'll just quickly touch on that, which is sort of doing our best to integrate with the available data sources that are out there, be that health systems, be that laboratory, be that radiology, all of these disparate pieces of information that don't necessarily talk to each other. Can we find a way to mesh those together? We're very fortunate, at least in Northeast Ohio, to have a very robust health information exchange that allows us to, on some level, share information, at least as it relates to clinical care, medications, problems. And certainly when there is an acute crisis, say psychiatric admission, we have visibility into what's going on there. I think on the sort of human side, it's really about relationship building and very much making sure that folks know, at least from our perspective as a medical practice, that we are available 24/7 and we want to be involved, that no communication is going to be overlooked. And so not only do we provide our contact information, and again, that's any mode that people want, right? That's phone, of course, that's email, that's our portal, that's direct outreach to our clinicians or the care team that's taking care of these individuals. Not only we're giving that to the patient, but we're also giving that to all of the other folks that are part of the ecosystem. That could be Direction Home, that could be, APS, that could be other specialty providers, mental health providers. Just trying to, when we talk about primary care as the quarterback, and I apologize for using a sports metaphor, when we talk about primary care as the quarterback, we really try to make that, if you don't know who the quarterback is, how can you actually have somebody who's sort of trying to make all these linkages? And so one of our objectives is really to get the information about our role and our interest in wanting to coordinate care to all the various people, right? And I think that unfortunately most primary care is really, really busy. And I think that is not that it's not true for us, but I think we're trying to make a very conscious effort to put ourselves out there as wanting to receive that information and doing our best to be a connector and an advocate for patients, ultimately.
Thank you. Ms. Varga, for the cases that you all have seen, can you see any type of severe gap that is present that really would be of value if we could address the barrier?
Some gaps that we see locally here are the lack of quick linkage to mental health or SUD services for older adults. In these services, as many others, the loss of the workforce is key to that. But also, we do have many mental health and SUD service providers in the area, but they all have waiting lists. And there is a priority placed on children and families to receive these much needed services first. There's also no longer an inpatient floor for adult mental health services at our local hospital. We did have that previously. The pre-screen can still be completed at the hospital. Then the search for space begins for the inpatient services needed. And as Ms. Smith spoke to earlier, finding a bed does not guarantee the specific needs of our older adult will be a priority and addressed appropriately or at all. Fairfield County also has an overwhelming gap in affordable, safe housing for older adults. Being homeless then precipitates many forms of abuse, neglect, and other maltreatment. On the surface, Lancaster, Ohio, has many new apartment complexes. However, none of these new complexes are affordable to our older adults that are on a fixed income. On that same note, transportation is a huge barrier. Fairfield County now has a public transit system, which is a wonderful resource. However, for the older adults who require assistive devices for their ambulation, the public transit can be a difficult last choice in transportation. The drivers cannot assist with getting the older adults safely into their destination. This is due to liability for the safety of the rider, and the bus cannot be left unattended for any amount of time. So those are just a few of the gaps that we see on a daily basis that are really need to be addressed strongly here.
Thank you. And Jennifer, I want to ask you that same question. In your work in the field, do you see any significant gaps that if we could address those barriers, it would alleviate some of those issues?
Sure. I think the gap I see is that families don't know what is available to them. By the time my team gets involved, like everyone's at their breaking point. Usually it will come from police or families call the crisis line and we go see a family and we're the first people that they've ever reached out to. And there are services, like we can get them linked with local agencies like Senior Options and stuff like that, and they didn't know. So I don't know how these agencies can get the word out more, because we don't even often know. Like when we have time, we will take time to like call around ourselves and see what's out there. But I mean, sometimes we're just like probate or don't probate, and we close them and try to give them a packet and let them navigate themselves. So I think the gap is just the information of all the different agencies in each county. And also, I mean, it seems like every county is doing different things. So that is frustrating when this whole conference is for all of Ohio. It's hard to discuss like what here in Franklin County wouldn't apply to maybe Dr. Mehta's county. So I think that is the gap. It's just information being widely available for everybody.
If I can piggyback off of what Jen's saying, because I think that's 100% correct. The other issue, and I apologize that I'm jumping in and I'm going to have to jump out shortly, but what we're watching is that stigma of any psychiatric conditions continues to be an issue. And we're watching young generations with unprecedentedly low levels of stigma, but families and older patients still carry some of that. And speaking to dementia for a minute, simply because it's the disorder that is most common onset in later, the psychiatric condition with onset in later life. I even have this in my own family. I have folks who I don't want to upset somebody about talking about their memory. I don't want to upset somebody about talking about they're not safe anymore. I don't want to upset anybody or acknowledge for myself that my loved one actually is not quite as sharp as they used to be and maybe now in harm's way. And then to Jen's point, that bruise and bruise and bruise until nobody can ignore it anymore. And then we find ourselves in a crisis. So it is fantastic that with younger generations, we're getting to the place where people openly talk about mental health of all types: depression, anxiety, bipolar disorder, psychotic disorders, take your substance abuse, take your pick. But we have to remember that that is still pretty entrenched in middle-aged and older folks. And that unfortunately lets some of these things brew in such a way that then we're left at the moment of crisis. And it's like, wow, now what do we do? And to the point being made here, now we're in crisis and these systems aren't lined up to actually address this. So there's things that we can do on the clinical side. There's things we have to do on the public health front too.
Thank you so much, Dr. Stroh, for that. And I know you have to go, but before you go, if you had a magic wand, what would you like to see?
Oh, that's the hard one. I only get the one wish. No.
Specific to older adults.
Yeah, no. I hear you. If I had a magic wand for older adults, it would probably be a more unified structure, and to the point that Jen's making, not necessarily 50 different ADAM boards of care, not necessarily 88 different counties of care. There needs to be kind of a unified standard by which people can say, this is how I do this. This is how, if I'm an Ohioan, I don't care if I live in Toledo or Lima or Athens or Columbus or wherever. I have a routine set of services that are easily accessed. It's not lost on me that we're making huge strides on a 988. I dial a number and the system, it's a no wrong doors approach. It simply helps guide me through the right way. If we had that for older adults who by definition are going to have more trouble navigating complex systems, that would be a godsend.
Mhm. Thank you so much. Thank you to our panel. And we're going to let Dr. Stroll gracefully depart. And we are going to have some open time for questions from the audience. So I think, Elijah, if you have anything that you see in the portal that may be some questions that need to be asked, let's take it away.
Good afternoon, everyone. We did have a question come in a little bit ago, and I'm not sure if anyone would have an answer for this, but the question is, we received a call from one of our county sheriffs requesting information on the training that his deputies could go through to help them navigate encounters with folks suffering from dementia. Does anyone have any recommendations?
Dr. Mehta or Ms. Varga, would you be able to address that?
Yeah, I'm not personally familiar with specific trainings for lay people on how to manage dementia care. Yeah, I think if I were probably advising this department, I would probably suggest that they reach out to local social worker, geriatrician, just to give a sort of informal talk on sort of tips and tricks. Yeah, I'm sure that there are actually, I'm curious actually if folks know about this or not, if there are YouTube videos or just, sort of open source materials on how to work with older adults. I'm sure the American Geriatric Society has something maybe on their website.
Yes, and I do know that within local communities, the Alzheimer's Association does a lot of local trainings as well.
That's a good one.
That's
what I was going to add. They have a lot of online access right now too, just because of that infrastructure. So they have some live trainings and recorded trainings. But I would, agree with partnering with maybe a local clinician or provider or somebody who do an in-service either on a regular basis or just a one-time situation. I know we utilize that a lot with frontline staff and nursing, and we do it regularly and often. So it's a helpful tool, and then that'll build kind of the partnerships and the point of contact if they're, that may develop over time too.
Thank you all. So a couple of comments came through the question and answered, but just to kind of build off that, a few people suggested contacting like the Alzheimer's Association. There is an online, and they do virtual classes on this. Someone also suggested maybe it's part of the crisis intervention team training that is specific as a specific training for law enforcement. I'm not sure if any counties in Ohio add dementia, but that might be an opportunity there. So thank you all.
Did we have any other questions in the portal?
Not yet. A lot of people are just responding to that question. So right now, if anybody has any questions for our panelists, you can add those to the question and answer box. We do have a question here. Does anyone know of resources for aging caregivers who need help putting together advanced directives for themselves and for their loved ones who they care for? So
I would recommend Alzheimer's Association again. They're invaluable with helping caregivers get, things in place that they need, or, a social worker at any local facility or agency they might be working with. There are online forums for that too, but it's usually helpful to have someone kind of walk you through it. I know it can be overwhelming. We have a lot of initiatives, I know, at our VA to make sure everybody's has one in place, and some ethics programs that we're piloting in order to ensure that everybody has it in place. We all need to do it more than we do. So there are some avenues out there.
Mhm. And for mental health, sometimes you can contact your local NAMI. That it can really be a valuable resource, as Ms. Renee Smith was speaking to as well. So you all have been an awesome panel. We really appreciate all of your contributions. You really give us a way to begin to work together closely with our systems, with aging and mental health. And we're glad that you're there. Thank you for all of the work that you do. And I will turn it back over to Molly.
Adrina, we actually have until about 12:30 to continue asking some more questions, if you'd like, just to give you some more time. Absolutely. For anybody that is still wondering, please feel free to ask any questions in the chat, and we'd be happy to answer them. I know there's one question here from an anonymous attendee that said, what would other panel members say to Adrina's magic wand question? And I thought that would be a good question to ask the panel.
Yes, that is excellent. So if you had a magic wand, and this is for any of the panelists, and you could really see something of value being done in our system specific to older adults in crisis, what would that be?
So I'd have to say,
Oh, go ahead, Kate, please.
I would have to say that centralized, that communication, that open communication between all providers from every avenue. I think that's super key. A centralized crisis service area would be wonderful for older adults, specific to older adults. If I had a magic wand, that is one place that I would start with, to make a crisis service, a centralized crisis services facility or organization and stabilization for older adults, to include mental health services, SUD services, medical, financial, guidance for homeless, and all those providers would cooperatively develop plans of action for the older adults specific to each individual, maintain contact with each other, and remain involved long after the older adults separate from that level of care.
Yes. And I think, Ms. Varga, from our standpoint too, what you're doing in terms of the cross training that you mentioned with all of the systems that you work with, I think that would be so valuable, so that each system understands their process, how you access it, what it does. Some of the specialty areas that the system may have that could really be elevated so that it could be more used in the community or what have you. So I think what you're doing is a wonderful offering to the global community as well, to do that cross-training.
Thank you. It really has enhanced joint services. We have our community paramedics actually go out with our APS workers several times a week to visit our older adults. Also, our visiting docs will go with our APS workers. It has really enhanced services here.
Mm-hmm.
I do see one more question here that might be good for the panel to answer. Is someone said, are there common, oh, I just lost it here. Are there common questions or concerns that older adults have when they become involved with services in each of your respective areas?
Yeah, well, I'll take that one just from my perspective. Especially, it sort of might also answer the magic wand question. And I think one of the things that I've been surprised to find is that, during the pandemic, I'm sure you guys have read these statistics, that in-person care went from about 95% in-person to about 5% in-person for about a year and a half. And what was taking up the bulk of those interactions was telehealth. And so a lot of folks got used to telehealth. And I've been personally surprised at how quickly we've swung back to going back to in-person without taking advantage of what I think of as incredibly useful, now easy to use, widely adopted solutions to improve access. We've talked a lot today about workforce constraints. Part of the problem with our workforce constraints is that we don't create a good working model for the people who might want to be in this field. And what we found that, at least in my practice, we're able to recruit great people because they have a mix of in-person and telehealth to provide great care to the people that they want to be serving. But we haven't taken advantage of that, I think, more broadly. And so my magic wand hope would be to, I guess, threefold: destigmatize, and improve adoption, and I think very importantly, reimburse these, I think, very valuable interactions that might be over audio and video like we are today, that while not perfect, right, like that they're not 100%, can get us 95% of the way towards a meaningful interaction with patients. And we found in our own clinical practice that we can do the vast majority of things that we want to do for patients virtually. And it helps to expand our care team. It helps to improve access. It helps to create 24/7 care for folks. And so I think to answer the second question, which is what do people get sort of, I don't know, worried about when they join our practice, is like, oh, well, there's no way I can figure this out. And it turns out that sometimes folks just need a helping hand. And once they've figured it out once, they see how easy it is and how much more convenient it is to not get dressed, get in a car, sit in a waiting room, get taken back to an exam room, get seen for 2 minutes, and then have to do the whole thing in reverse, rather than simply pushing a button and seeing your dedicated care team that knows you and can therefore spend much more time with you. And I think we've as a society have not embraced some of these very simple technological solutions as much as we could and should. So that's kind of my selfish wish.
Great, that was awesome.
We did have another question come in, and this is specific to the I team. But is there ever a need for different I teams interact or collaborate with one another? How do I teams interface with the community mental health system?
So I will talk about I-teams in Fairfield County, and I'll talk about the mental health interaction with I-team. We have invited all of the mental health agencies within Fairfield County to sit and participate on our I-team. Due to scheduling, it's difficult for clinicians to attend. So mostly we have to reach out outside of that meeting to collaborate with mental health. We don't have a lot of participation in the meeting itself. However, they have come to the table to do the cross training, which has been extremely helpful, especially on the crisis response. So, and I'm sorry, the first part of that question, I jumped to the last part and I don't remember what the first part was.
Yeah, so the question was about if different I teams interact with each other and collaborate with each other.
I have had folks from different counties ask to come and just visit our I team. But as far as ongoing working across the county lines, I haven't seen much of that. I don't know if anyone else has.
And one of the issues there too is that sometimes depending on the county, just like Dr. Sturm was saying, the IT may vary in its structure and how they do their work. So that's a issue. Ms. Varga, if we were going to look at incentivizing mental health workers to be a part of your work a little bit more closely, because they do have those productivity issues that they have to deal with during the workday. Do you have a solution or any kind of helpful tips that you would suggest to incentivize that participation?
So it would mainly be for the case managers to attend visits with our APS workers.
Mm-hmm.
That's the one thing that I can think right off the top of my head.
Mm-hmm.
And that would be billable hours for the case manager as well.
Thank you.
We have a question that came in for Dr. White.
Mm-hmm.
Are there veteran-specific concerns for older adults that you've seen?
That's a tough one to answer. Because that's my world. I would just say, the complexity of the biopsychosocial issues are profound, as they are in the community as well. But we just have a lot of cultural generational aspects with the military cultures as well. So we have kind of a wave with the Vietnam veterans and, unique considerations for their era as well. I do think we have a lot more access to some resources because of that, but again, utilizing them, communicating amongst them is a big issue. It gets very complex for them. I would say one of the biggest things which was discussed today and which was something that I definitely wish we could kind of wave the magic wand is a overarching approach to trauma-informed care, as was discussed today. There's some unique needs of our veterans, anybody we work with, but we know there's a high risk of trauma in that population, but that also extends to the caregivers, the mental health professionals, the nursing staff, working with complex cases too. So I really think that trauma-informed framework is something that we need to implement a lot more, and that, for veteran unique needs. I could go on, of course, but I hope that answers a little bit of the question.
Thank you. We had a question come in for Dr. Mehta. How often do you find that people you serve are not already connected with community mental health services? Are there challenges in making this connection when needed?
Yeah, I think that there are certainly folks who are connected with community mental health services. We are often identifying people who do need those connections to be made. I think there are two significant barriers that we're encountering, maybe three. One is transportation. So getting folks to be able to be seen has been very challenging for especially for underserved populations or folks who are socially isolated or don't have family members who can help them. Just frankly, getting there can be a challenge. I think number two is access, right? Just the availability of mental health providers can be challenging to get in to see folks. There's often long waiting lists. And I think the third thing, I hate to be beating this drum over and over. I'm going to promise you, I'm not. I don't have any stock in this telehealth thing, but I think that if more telehealth provision was available, we'd be able to potentially allow people to stay home and still connect with mental health resources from the comfort of their home. To that end, I think at least my organization, Heyday Health, is actually thinking about bringing mental health providers onto our staff so that we don't have to rely on community mental health providers. It's not to say that we want to duplicate or usurp or we just want to add capacity, which I think we'd all probably agree that there is constrained capacity and supply right now. And so we're just hoping to add to that. So I think those are the couple of challenges that we've been facing.
Yes, that's a very important subject that you hit on there. We recently had a focus group of older adults, and they said, why can't the mental health services come to our place? So their housing environment. They were talking about, I'm over 80 years old. Why can't they come to me? And it was like, yeah, why can't we go to you? So I do think, trying to expand the way we think, and then having some of those older adults in our decision-making process to help us to understand their world and accommodate them better. So thank you for that, Dr. Mehta.
I was going to add, in our facility and VA in general, we have mental health providers embedded in every medical service. So we're all over, like literally any primary care visit, medical service you have, there's a psychologist kind of staffed to that area, which is very beneficial for screening and getting access to that mental health care.
Mm-hmm.
We had a few more questions come in. I think Dr. Mehta will have an answer for this one, but it's open to anyone. How receptive are older adults to telehealth services? And how do they receive assistance if needed?
So I kind of touched on this a little bit. I think initially folks are hesitant, right? Because I think that there's a sense that you need to be, touch and see and hold, in order to provide great care. However, I think that once people, A, see that it's easy to use, B, see that they can get everything that they would want or need from an interaction that is a telehealth interaction, people tend to love it. In fact, they often say they would never go back to the other way, because why should I waste my time and half a day of work? Even more importantly, for a lot of folks, half a day of my caregiver's life, that they have to take off of work for half a day to take me to an appointment where I see the doctor, nurse practitioner, whomever, for 3 minutes. Like, is that really worth it? Mm-hmm. And I think that so telehealth is, again, it's not for everyone. It's not perfect. I'm not claiming that by any stretch of the imagination. I am saying, however, that for folks who it's appropriate for, it can be a godsend and it can be a real lifeline. In terms, and the second question was like, well, what kind of support and resources are there? The good news is that there are lots of organizations that are out there that are providing either help or tech support. In our area in Northeast Ohio, there's an organization called Family Tech Connect, which is a grant-funded nonprofit that helps people get onto basic electronic gadgets to connect with loved ones or to healthcare providers. In our case, I mentioned our role, the Health Ally. Our Health Allies, one of their roles is to actually show patients and their families how to use smartphones. What we found in our population, believe it or not, is that about 80% of our patients have a smartphone. They might not use it as a smartphone, but they have a smartphone. And then the remaining, probably 15% of the remaining 20 have access to someone with a smartphone, family member, loved one, neighbor, caregiver, health aide. Somebody has a smartphone that they can, if they can push a button and receive a text message, they can typically get connected with a provider. So I think the ubiquity of smartphones, fortunately, is helpful for this.
Great, thank you.
I would say the provider's ease as well. Like, I think we're just your comfort level and, you know, some biases we have about who will latch onto it or do well with it. Because I'll have like 5 different ways I'm going to have an option to connect with somebody. And if I'm like confident and encouraging them, you know, they may be reluctant, but we can get through this barrier and they say, oh, this worked really well. I've had countless feedback forms sent in. Like, I was really skeptical about this, but you know, we made it work, and it's for something that worked in my home. So I think just all of our biases about that play an important role too.
Yes, thank you. Well, I don't think we're going to be able to get through the rest of these questions before wrapping up, but I want to just thank you all for taking some time to answer, you know, so many of the questions today. Sorry we couldn't get to all of them. But Molly, do you have any final instructions before we depart?
I do not. I just want to say thank you to Adrina and to our panel here for providing, you know, just such a really enlightening discussion surrounding older adults and crisis services. I think there's a lot of really good ideas that and solutions-oriented focus. Before we wrap up, though, I'm just going to say thank you to everybody for attending and for our panelists and for putting on such a great academy. I'd also like to thank our sponsor, the Ohio Department of Mental Health and Addiction Services. And again, everybody we connected with through the Aging Department and an Aging Task Force for just pulling this academy together. I'm going to send a link to the 2-part survey. You will also receive this in an email later today. I will include in this email presentation materials and contact information for anybody interested in learning more. And then I'll also include Adrina's note about joining the AG CJMI task force as well. So please complete in regards to CEUs, please complete the evaluation here in the future to inform our future trainings and to receive your certificate. And those in attendance specifically requesting CLEs, I do have to show an activity code. So here it is. Let me just put it in full screen here. Okay. Pardon, 1 second. Here it is. Thank you all again, and let me put this in the chat real quick.
Thank you again to our amazing panelists for taking your time and sharing with us. It is really appreciated. We really do appreciate you.
Yes, thank you all again. And I'll just leave this activity code up for those viewing. Thank you all. And that concludes our academy. Thank you all to everyone for joining.
Thank you, Elijah and Molly. You did a great job. Thank you. Thank you.
Thank you. This is wonderful. All right, I'm going to go ahead and close the academy. Thank you all again